चल। खाना खाने गए।
चलो
कितना बोल रहे थे?
थोड़ा ही है, चल पहुंचो तुम अपनी अपनी सीट्स पे।
नहीं किलोमीटर।
हाँ 1 मिनट शुरू करना है, पीछे हो जाता है वैसे। एक तो कोई
एक सेकंड, जब दीपिका का हंसना बंद हो जाए। अच्छा चल चल। गुड मॉर्निंग करते हैं। कर दे। I'm sitting.
Good afternoon, everyone. I hope all of you had your lunches because the next activity is about to serve yet again. We have with us Dr. Kamardeep Singh, Professor and in charge, VRDL GMC Amritsar, and Director PIMS Jalandhar. We also have Dr. Jayashree, which I already introduced. So, across the vast syllabus that this course offers, all of the students, including me, we have all learned about infections in textbooks. We've seen the symptoms, we've learned the science, and memorized the microbes. But today, it's about time we flip the script. So, where here we will all witness infections walk right into clinic in front of us. Microbes speak through the patients themselves, a novel way to see a disease form up and make sense right in front of our own eyes. Much like the books were given a chance to bring on that drama club. Welcome to our next activity, the highly anticipated role play of stimulated patient doctor interaction, highlighting the clinical presentation of infections across multiple domains of healthcare team. Microbes meet the patient. Please listen to every word carefully. The activity had departments running around catching students for that. For this activity, the first team would be the department carrying tiny wonders, the Department of Pediatrics, presenting meningitis to be judged by Dr. Jayashree M. The stage is yours, pediatrics team.
ਡਾਕਟਰ ਸਾਹਿਬ ਮੇਰੇ ਬੱਚੇ ਨੂੰ ਵੇਖਿਓ ਕੀ ਹੋਇਆ ਹੈ। ਕੋਈ ਗੱਲ ਨਹੀਂ, ਤੁਸੀਂ ਆਰਾਮ ਨਾਲ ਸ਼ਾਂਤੀ ਨਾਲ ਬੈਠ ਜਾਓ ਔਰ ਆਰਾਮ ਨਾਲ ਦੱਸੋ ਮੈਨੂੰ ਕਿ ਕੀ ਦਿੱਕਤ ਕੀ ਆ ਰਹੀ ਹੈ ਤੁਹਾਡੇ ਬੱਚੇ ਨੂੰ। ਡਾਕਟਰ ਸਾਹਿਬ ਮੇਰੇ ਬੱਚੇ ਨੂੰ 7 ਦਿਨਾਂ ਤੋਂ ਬਹੁਤ ਤੇਜ਼ ਬੁਖਾਰ ਹੈ ਤੇ ਇਹਨੂੰ ਸਵੇਰੇ 10 ਮਿੰਟ ਦੌਰਾ ਵੀ ਪਿਆ ਸੀ, ਬਹੁਤ ਜ਼ਿਆਦਾ ਸਿਰ ਦਰਦ ਵੀ ਹੋ ਰਿਹਾ ਹੈ ਤੇ ਉਲਟੀਆਂ ਵੀ ਆ ਰਹੀਆਂ ਹੈ। ਠੀਕ ਹੈ ਨਰਸ, ਪਲੀਜ਼ ਅਟੈਚ ਦ ਮੋਨੀਟਰ ਐਂਡ ਚੈੱਕ ਦ ਵਾਈਟਲਸ ਆਫ ਦ ਪੇਸ਼ੈਂਟ।
Monitor is attached. Ma'am, temperature is 101.8 degree Fahrenheit. Heart rate is 118 per minute. Respiratory rate is 26 per minute. And saturation of oxygen is 98% at a room air. And the GCS is 13/15.
Okay, nurse. Okay, sister nurse. Thank you.
This is a triage form which is filled by a hospital, and it has two parts: the general assessment, which is a triangle which involves appearance, work of breathing, and skin circulation, and secondly, it has a pentagon which involves airway, breathing, circulation, disability, and exposure. Scene two: setting, emergency observation bay. Initial assessment and stabilization is performed by residents and hospital staff.
सिस्टर प्लीज़ एक्सेस आईवी एक्सेस स्टार्ट कीजिए एंड अगर इनको दोबारा से मतलब सीजर्स हो रहे हैं तो इनको आईवी मिडाजोलाम 0.2 मिलीग्राम पर केजी से स्टार्ट करना है।
और इनके सारे सैंपल्स, इनके सीबीसी, सीआरपी और ब्लड कल्चर भी डिफरेंट डिपार्टमेंट्स में भेज देना।
Okay, ma'am. IV is attached and monitor is attached also, and vitals are stable now.
Scene 3: History and examination. Clinical findings of meningitis.
हाँ जी, ਅਸੀਂ ਤੁਹਾਡੇ ਬੱਚੇ ਨੂੰ ਦੇਖ ਰਹੇ ਸੀਗੇ ਤੇ ਅਸੀਂ ਕੁਝ ਪੁੱਛਣਾ ਸੀ ਤੁਹਾਡੇ ਤੋਂ। ਤੁਹਾਡੇ ਜਵਾਕ ਨੂੰ ਕਦੇ ਸੱਟ ਲੱਗੀ ਸੀ?
ਨਹੀਂ ਜੀ, ਕੋਈ ਸੱਟ ਨਹੀਂ ਲੱਗੀ।
ਅੱਛਾ, ਇਹਦੇ ਕੰਨ ਚੋਂ ਕਦੇ ਕੋਈ ਪਾਣੀ ਪਿਆ ਹੈ? ਕਦੇ ਮਤਲਬ ਪਾਣੀ ਬਹਿ ਰਿਹਾ ਹੋਏ ਜਾਂ ਕੁਝ?
ਨਹੀਂ ਜੀ, ਇਦਾਂ ਦੀ ਤਾਂ ਕੋਈ ਦਿੱਕਤ ਨਹੀਂ ਸੀ।
ਕਦੇ ਕੋਈ ਬਿਮਾਰੀ ਹੋਈ ਹੋਏ, ਟੀਬੀ ਹੋਇਆ ਹੋਏ, ਲੰਬੀ ਦਵਾਈ ਚੱਲੀ ਹੋਏ?
ਨਹੀਂ ਜੀ, ਇਦਾਂ ਦੀ
ਨਹੀਂ,
ਕੋਈ
ਐਸਾ ਕੁਝ
ਦਿੱਕਤ
ਨਹੀਂ
ਨਹੀਂ
ਹੋਇਆ।
ਸੀ।
ਚਲੋ, ਤੇ ਇਹਦੇ ਇੰਜੈਕਸ਼ਨ ਲੱਗੇ ਹੋਏ ਨੇ? ਸਾਰੇ ਟੀਕੇ ਲੱਗੇ ਹੋਏ ਨੇ?
ਹਾਂਜੀ 5 ਸਾਲ ਤੱਕ ਸਾਰੇ ਲੱਗੇ ਹੋਏ ਆ।
ਸਾਰੇ ਲੱਗੇ ਹੋਏ ਨੇ, ਠੀਕ ਹੈ। ਤੇ ਸਕੂਲ 'ਚ ਕਿਵੇਂ ਆਪਣੀ ਬੱਚੀ?
ਵਧੀਆ ਹੈ ਜੀ, ਵਧੀਆ ਪੜ੍ਹਦੀ ਹੈ।
ਵਧੀਆ ਪੜ੍ਹਦੀ ਆ, ਠੀਕ ਹੈ। ਥੈਂਕ ਯੂ।
So after history taking, now we'll perform some examination on the patient. So first we'll perform the Kernig sign. So the patient winces when we hyperflex the leg. Then we will do the Brudzinski sign, in which we will do the passive neck flexion. So Brudzinski and the Koenig sign are positive in this patient.
Scene 4. Consultant review and plan. Consultant was informed by the staff and he arrives in the ER.
What is the case summary?
So this is the case we have been looking for the meningitis.
Sir, this is a case of a 7-year-old patient who presented in the emergency today itself because she has a seizure this morning. She has also a history of 7 days fever and headache, and also she has projectile. Sorry, also she has vomiting, and now we are suspecting meningitis in this patient.
Uh, Good job. So, what are the differentials?
So we are keeping the differentials of bacterial meningitis and as well as viral meningitis, tubercular meningitis.
चलो इनका रूटीन इन्वेस्टिगेशन कराना, उसके बाद इनका लंबा पंक्चर भी कराना, और मुझे ये बताओ व्हाट आर द इंडिकेशंस ऑफ इमेजिंग.
So imaging is done in case of papilloedema, in case of increased ICP, intracranial pressure, in case of sensorium or yes,
Excellent. So ऐसा करो, start IV ceftriaxone and vancomycin after sending the cultures. Okay.
okay, okay, sir.
Scene 5. Lumbar puncture consent and preparation.
हम ना अभी आपके बच्चे को देख रहे थे, कुछ सैंपल्स भेजे हैं आगे देखने को कि क्या होगा। उसके अलावा हमें एक टेस्ट करना था। हमें आपके बच्चे की रीढ़ की हड्डी में एक सुई डालेंगे और उससे हम एक पानी निकालेंगे जिसको हम फर्दर देखेंगे कि उसमें क्या आता है, उसके हिसाब से हम बच्चे को ट्रीट करेंगे। हम उसमें कुछ वो 10 से 15 मिनट का प्रोसीजर होता है और उसमें कुछ ज़्यादा नहीं होता है। उसमें मतलब हो सकता है इन्फेक्शन हो सकता है या उस जगह पे थोड़ी देर के लिए दर्द रहेगा। चांसेस कम होते हैं कुछ भी खराब होने के, बट आप एक बार ये फॉर्म है, आप इस फॉर्म को पढ़ लें और उसको साइन कर दें। एक बार फॉर्म देना।
डॉक्टर साहब मेरे बच्चे ਨੂੰ ਕੁਝ ਹੋਏਗਾ ਤੇ ਨਹੀਂ?
नहीं नहीं, बच्चे ਨੂੰ वैसे कुछ नहीं होएगा, बट इस फॉर्म में सब कुछ लिखा हुआ है, तो एक बार पढ़ लो, फिर जो सोनू लगे कि ठीक है या कुछ सोनू दिक्कत आए, कोई डाउट होए तो मेरे तो प्लीज पूछ लियो। हेलो।
ਹਾਂਜੀ ਤੁਸੀਂ ਕਰ ਸਕਦੇ ਹੋ।
ठीक है, थैंक यू।
Scene 6. Lumbar puncture procedure.
या वो चादर उठा। So lumbar tray is ready. ऐसा
Yes, ma'am. Lumbar puncture tray is ready and area is also disinfected now.
so let's वही तो
ਬੇਟਾ ਤੁਸੀਂ ਇਦਾਂ ਕਰੋ, ਆਪਣੀ ਜਿਹੜੀ ਗੋਡੇ ਹੈ ਨਾ ਉਹਨੂੰ ਛਾਤੀ ਨਾਲ ਜੋੜ ਲਓ ਔਰ ਹਾਂ ਖੱਬੇ ਪਾਸੇ ਨੂੰ ਲੇਟ ਜਾਓ, ਖੱਬੇ ਪਾਸੇ ਨੂੰ ਲੇਟ ਜਾਓ।
चलो जेआर्स, मेरे को बताओ कि प्रोसीजर क्या होता है लंबा पंक्चर का.
सर सबसे पहले तो हम लोग आइडेंटिफाई करेंगे एरिया जहाँ पे हम लोगों को मेनली जो लंबर पंक्चर नीडल है उसको इंसर्ट करना है। तो उसके लिए हम लोग पेशेंट की इलियक क्रेस्ट जो है उसको पैल्पेट करके और एक टफियर्स लाइन होती है जो कि इमेजिनरी लाइन होती है बिटवीन टू इलाइक क्रेस्ट एंड वो L4 के लेवल पे होती है। तो हम लोग L3 L4 जो स्पेस होती है उसके बीच में निडल को इंसर्ट करेंगे और उससे पहले हम लोग सबसे पहले एरिया को डिसइंफेक्ट करते हैं, फर्स्ट विद द पोविडोन आयोडीन एंड देन विद क्लोरहेक्सिडिन, एंड फ्रॉम इनसाइड टू आउटसाइड वे में। और उसके बाद सर हम लोग जो निडल है उसका विद द बेवल ऑन इट्स अपर साइड टुवर्ड्स द सेफिलिक, इन द सेफिलिक डायरेक्शन हम उसको इंसर्ट करेंगे धीरे धीरे, एंड मेनली पॉइंटिंग टुवर्ड्स द अम्बलाइकस।
पैल्पेट कर पा रहे हो L3 L4 स्पेस?
यस सर।
ठीक है, कितना CSF ड्रेन करोगे फिर?
सर मेनली हम लोगों को 3 सैंपल चाहिए होते हैं, 20 ml CSF हम जो है ड्रेन करते हैं, और एक सैंपल हम लोग ग्राम स्टेनिंग और माइक्रोबायोलॉजी लैब के लिए भेज देंगे, एक में हम लोग सेल्स काउंट जो है उनके लिए और शुगर एंड प्रोटीन लेवल्स के लिए भेजते हैं।
ठीक है, परफॉर्म द प्रोसीजर।
CSF अपीयरेंस थोड़ी मतलब टर्बिड सी लग रही है, और नर्स प्लीज़ आप ये 3 जो सैंपल्स हैं वो एज सून एज पॉसिबल उनके रिस्पेक्टिव डिपार्टमेंट्स में पहुंचा दीजिए।
And vials are collected and samples are sent to biochemistry pathology labs respectively.
Okay, thank you.
Scene 7, Lab Coordination and Result Interpretation.
Dr. Nikita, I think we should call our lab technician to just send our samples as soon as possible as they can. हेलो डॉक्टर नेहा। डॉक्टर नेहा, हमारे पास एक पेशेंट आया था, हमने उसका सैंपल्स भेजे थे, CSF सैंपल्स माइक्रोबायोलॉजी डिपार्टमेंट में। आपके पास उनकी रिपोर्ट्स आप हमें जल्द से जल्द करके भेज दोगे अभी?
Ma'am, it will take some time, but I will try as soon as possible.
ओके, थैंक यू डॉक्टर नेहा।
So, ma'am, these are the results. Microbiology result shows gram-positive diplococci, and it is most likely Streptococcus pneumoniae. And pathology shows CSF shows 800 cells per cubic mm, and biochemistry result shows proteins are 150 milligram per deciliter, sugars are 20 milligram per deciliter, and random blood sugar is 100 milligram per deciliter.
थैंक यू डॉक्टर नेहा।
सो क्या लगता है, क्या डायग्नोसिस होगा?
So, most probably it is acute bacterial meningitis, likely Streptococcus pneumoniae.
सर क्योंकि जो अभी CSF में फाइंडिंग्स आई हैं तो उसमें भी मतलब पॉलीमॉर्फो न्यूट्रोफिल्स दिखे हैं और सेल काउंट बढ़ा हुआ है एंड ग्लूकोज लेवल कम है, प्रोटीन्स भी एलिवेटेड आए हैं उसमें, एंड ऑल्सो स्टेनिंग पे, ग्राम स्टेनिंग पे उनको स्ट्रेप्टोकोकस निमोनिया दिखे हैं, तो मोस्ट प्रोबेबली एक्यूट पायोजेनिक बैक्टीरियल मेनिंजाइटिस होगा।
ठीक है, फिर कंटिन्यू द एंटीबायोटिक्स, फ्लूइड्स एंड मॉनिटर द न्यूरोस्कैन्स, और जो पेरेंट्स हैं उनको काउंसल करो कि आफ्टर रिजल्ट्स क्या होगा।
ओके, थैंक यू सर।
Scene 8, Counseling of Parents.
ਨਮਸਤੇ। ਤੁਹਾਡੇ ਜਵਾਕ ਦੇ ਸਾਡੇ ਬੱਚੇ ਦੀ ਆ ਗਈਆਂ ਰਿਪੋਰਟਸ। ਉਹਦੇ ਹੁਣ ਅਸੀਂ ਜਿਹੜਾ ਸੈਂਪਲ ਲਿੱਤਾ ਸੀਗਾ CSF, ਅਸੀਂ ਜਿਹੜਾ ਸੂਈ ਰਾਹੀਂ ਕੀਤਾ ਸੀਗਾ, ਉਹਦੇ ਰਿਜ਼ਲਟਸ ਆ ਗਏ ਨੇ, ਅਤੇ ਉਹਦੇ ਵਿੱਚ ਸਾਨੂੰ ਪਤਾ ਚੱਲਿਆ ਕਿ ਤੁਹਾਡੇ ਬੱਚੇ ਨੂੰ ਇੱਕ ਐਕਿਊਟ ਬੈਕਟੀਰੀਅਲ ਮੈਨਿਨਜਾਈਟਿਸ ਲੱਭਿਆ ਅਤੇ ਨਿਕਲਿਆ, ਅਤੇ ਉਹਦੇ ਵੇਲੇ ਅਸੀਂ ਹੁਣ ਉਹਦਾ ਟਰੀਟਮੈਂਟ ਕਰਨਾ ਚਾਹਾਂਗੇ। ਅਸੀਂ ਕੋਸ਼ਿਸ਼ ਕਰਾਂਗੇ, ਬਟ ਇਹਦੇ 'ਚ ਕੁਛ ਨਹੀਂ ਹੁੰਦਾ, ਅਸੀਂ ਐਂਟੀਬਾਇਓਟਿਕਸ ਚਲਾਵਾਂਗੇ, ਟਰੀਟਮੈਂਟ ਦੇਵਾਂਗੇ, ਅਤੇ ਸਾਡਾ ਬੱਚਾ ਠੀਕ ਹੋ ਜਾਏਗਾ ਮੋਸਟ ਪ੍ਰੋਬੇਬਲੀ।
ਤੁਸੀਂ ਕੁਝ ਪੁੱਛਣਾ ਹੋਵੇ ਜਾਂ ਤੁਹਾਨੂੰ ਕਿਸੇ ਚੀਜ਼ ਦਾ ਮਤਲਬ ਕੋਈ ਡਾਊਟ ਹੈ?
ਕਿਸੇ ਗੱਲ ਦਾ ਧਿਆਨ ਤਾਂ ਨਹੀਂ ਰੱਖਣਾ ਪਏਗਾ ਸਾਨੂੰ ਖਾਸ?
ਨਹੀਂ, ਫਿਲਹਾਲ ਤਾਂ ਅਸੀਂ ਉਹਨੂੰ ਮਤਲਬ ਰੈਗੂਲਰਲੀ ਮੋਨੀਟਰ ਕਰ ਰਹੇ ਹਾਂ ਹਸਪੀਟਲ 'ਚ ਹੀ, ਔਰ ਕੁਛ ਦਿਨ ਐਂਟੀਬਾਇਓਟਿਕਸ ਚਲਾ ਕੇ ਫਿਰ ਆਪਾਂ ਉਹਨੂੰ ਭੇਜ ਦਾਂਗੇ ਤਾਂ ਉਹ ਠੀਕ ਹੋ ਜਾਏਗੀ ਬਿਲਕੁਲ।
Thank you.
That was an amazing play. Before moving on to the discussion of this case, I would like to introduce the rest of the judges for the day. Dr. Ankur Ahuja, Senior Consultant Cardiology, Fortis Hospital, Mohali. Please welcome them with a huge round of applause. We also have Dr. Deepika Gupta, Assistant Professor, Department of Anesthesia, Government Medical College, Chandigarh. Dr. Anupam Goyal, Senior Consultant, Laparoscopic Surgery, Max Super Specialty Hospital, Chandigarh. Now I would like to invite upon Dr. Jayashree for the case discussion and sharing her insights.
So it's a proud moment for me to have Dr. Jayashree here. Dr. Jayashree has been my role model, my teacher, my now even a colleague, and my dearest friend. So आज मेरे लिए बहुत ही अच्छा लग रहा है कि मैम यहाँ पे आए. So जब तक आप टीचर्स डे कर रहे थे तो मैं हर साल मैम को ही कार्ड देती. Every year. एंड आप लोगों ने वो मेरे से ले लिया कि आई कुड नॉट गिव अ हैंडमेड कार्ड. अब मेरे को 5 इकट्ठे बना के जाके देना पड़ेंगे. So she is the one who has taught me during my junior residency. So she was a senior resident and currently she is professor and head of emergency intensive. And जितना मैम क्लिनिशियन अच्छी हैं उतना रेयरली एक बार ऐसा हो रहा था कि 32 में जाने वाले थे मैम, तो मैंने बोला आप उधर ना आओ क्योंकि पीजीआई नीड्स द पीपल हु आर द बेस्ट ऑफ देम. शी इज वन ऑफ द बेस्ट क्लिनिशियंस आई हैव एवर सीन. शी इज अ सो आई एम वेरी थैंकफुल दैट शी वाज. बड़ी देर से सोच रही थी कि मैम को बुलाना है, पर डॉक्टर मुरलीधरन को तो आपने पहले मिला हुए हैं, सो आपके बैच देखे हुए हैं, पर मैम को नहीं मिले थे. सो आज इट इज आई एम लकी दैट मैम वाज एबल टू accept the invitation. Thank you.
Thank you, Bhavneet, for those kind words. I'm feeling overwhelmed and reminded of our residency days. So you have taken me on a nostalgic trip now. Okay. Good afternoon, students. It's really a pleasure to be here, a part of this very unique and very innovative exercise, which really stimulates learning. I think this is probably so much better than just talking to you about meningitis through didactic lectures. This way you learn better. And I think the students of 2022 and 2024 batch, I think they've done an amazing job, right? So a huge round of applause. Yes. So what I'm going to do in this discussion is I'm just going to try to break up the discussion piecemeal and try to build a pyramid for you for how this case evolved in their role play. So whenever any patient comes to you with symptoms, the first step that we need to do is analyze that symptom complex. So usually the patient will come with 2 or 3 symptoms together. So what we can call as symptom complex, or we can say a constellation of signs and symptoms, whatever you want to say. So usually they will come with 3-4 symptoms. So this child came with fever, headache, vomiting, and seizures, right? With that symptom complex, the first step as clinician, what we need to do is, of course, we take history, what we call as history of presenting illness, like all of you have done here. What basically we are trying to do from history of presenting illness is 2 or 3 things. First thing is we are trying to see which is the organ system which is predominantly involved in this given child. So for example, in this child, it's CNS. I think it's quite simple because the child had seizure. So it became very easy for you to localize that probably this so-called infection is in the CNS. But CNS is a very broad thing, right? So we need to see where in the CNS. So stepwise we will go. So first is we need to zero in on to what is a symptom, this symptom complex, what organ system is involved. Second, we need to see what is the natural history of this illness with which the child has presented. Is it acute? Is it subacute? Is it chronic? Has it been modified by treatment? Is it progressive? Is it getting into complication? What is happening? So that is what your presenting complaint tells you. Third important thing is, what are the complications? It's simply an illness like meningitis, or it is complicated by, let's say, a subdural effusion. Is it complicated by some brain abscess? Is there something else that we need to see? And lastly, I think that is probably very important, because I work in intensive care. We need to identify whether there is anything life threatening in this history which needs immediate attention. And then only you can start going further ahead with your history and clinical examination. So this is the first objective whenever you approach a case. So in this particular case, the organ system involved was CNS. The child possibly could be having some complication. It seems to be a very acute illness which has progressed to seizures. And at least there was no life-threatening complication. But having said this, any child who has thrown a seizure once, there can be a seizure again. All of you agree? So that child can have a seizure again. So we must always anticipate that there could be a next complication in this particular child. So ऐसा नहीं होना चाहिए as clinician, अच्छा ठीक है अभी तो ठीक लग रहा है तो ठीक ही रहेगा, ऐसा नहीं. So you should always be on the vigil that there could be a next complication which can come in this child. So that's the first step, which very beautifully they demonstrated through the role play. Then the second thing you saw was they looked at triage. All of you saw the form that you people use to triage patients. What is triage? Triage is basically, if in an emergency there are 10 patients coming in at the same time, a single doctor or two doctors can't see all the patients together at the same time. All of you agree, right? So there has to be some way by which you sort out patients. Those who are sickest get to be seen first. Is this clear? So you need to sort out the patient, and the one who's, let's say somebody is gasping or somebody is throwing a seizure, obviously that patient needs to be seen first. And those who look relatively stable can be seen a little later. Whereas in OPD, you do the opposite. Line se dekhte ho, sequence se dekhte ho, token se dekhte ho, right? So in OPD, you follow the sequence of who comes first, that person is seen first. But in triage in emergency, it's the other way around. The sicker ones gets to be seen first. So what did they do in the triage? You saw that triage form. I'm sure all of you are very familiar. You are using it. Dr. Bhavani tells me that you are using it in your ER. So there you see that whether this particular CNS infection that we have analyzed in the history, whether that is causing any physiological problems to the patient. What can that be? That can be a seizure, that can be a apnea, there can be a respiratory failure. Maybe this child is having raised intracranial tension because of meningitis, which is complicated. There can be a hypoglycemia in this child. So these are some of the physiological complications which need to be immediately identified, and the patient has to be stabilized. Because if you don't do that and just, let's say, start antibiotics, the patient will die. So altered physiology needs to be always stabilized first. The basic diagnosis or etiology can wait for some time, and then you can treat it. So that's why triaging is the most important second step that you do, which very nicely your students have just demonstrated, right? Then comes the third thing is, then you saw that there was a girl who sat and called the parents and took a detailed history. What was she trying to do? She was basically trying to ask, okay, this looks like meningitis, but why has this child developed meningitis? Was there a trauma sometime? Was there a CSF leak, or what we call a CSF rhinorrhea? Did this child have, let's say, some pustule, some ear discharge? Was there some otitis media? So these are some risk factors for developing bacterial meningitis. All of you must have read in textbooks, right? Could this be a tubercular meningitis? Could this be a viral meningitis? So that focused history which she sat and took was basically to know what is the likely etiology for this particular syndromic diagnosis of so-called meningitis. Is that clear? See how stepwise it is going. And then you decide to do investigations. So when you plan investigations, they have to be very specific. They have to be targeted for the patient. And that investigation should be able to yield you what is the diagnosis. So kai bar I tell my residents in PGI, just because electrolytes are available, you send electrolytes for everybody. It's not required, right? So similarly, you must remember that you send investigations only which are targeted for a given patient. So they examined, they looked at Brudzinski's, they looked at neck stiffness, they looked at Koenig's. These are 3 signs which are quite typical of meningitis. Can there be any other condition where you can have a Koenig's and Brudzinski's positive? Anybody from the audience? It's positive, but it need not be meningitis. Anybody? Excellent. So these signs only mean that there is some irritation of the meninges, right? So that can happen even with a hemorrhage, like a subarachnoid hemorrhage. So here, because the child is having fever, vomiting, headache, and neck signs which are positive, it's the what do we call the probability of this being meningitis is much higher, right? And then you do a lab, which is the CSF, rightly. And here what I want to just emphasize is that before you plan investigations, you must give some empirical therapy. You understand what is empirical? You don't know that this is meningitis, but you have a high index of suspicion that this is meningitis. You have to wait for your CSF. You heard the microbiology person saying that, yes, I'll try to give the reports as fast as possible. But remember, in infections, the first shot of antibiotic should be given as early as possible, right? So therefore, you need to start an empiric cover. So what's the commonest organism which causes meningitis? Only when you know that, you will know what antibiotics to start before the CSF comes. So what is the commonest cause for bacterial meningitis? This child was 7 years old, I think, right? Yeah. Pneumococcus, yes. Staphylococcus, Staphylococcus aureus, pneumococcus, right? Staphylococcus can be both methicillin sensitive as well as methicillin resistant. So these are the is H flu common now? And if not, why? Because you have a good H flu vaccine. So the most of the bacterial meningitis we see is because of pneumococcus, streptococcus, and you see because of staphylococcus. Even meningococcus, which is seen more in the West, is not so commonly seen in our setup, right? So these are the so which antibiotic will cover all these 3? Ceftriaxone. You heard them say ceftriaxone and vancomycin. Okay. So empiric therapy. Now we are not giving dexamethasone. So previously it was recommended that you give dexamethasone, especially when you have an early diagnosis of meningitis, but before they receive their first shot of antibiotics. Now we know that many times when patients come to us, they've already received some oral antibiotics or some IV antibiotic outside. So now nowadays we don't use dexamethasone for meningitis. Okay, so lab interpretation, and then finally you got the organism, and then you continued the antibiotics. Now I want a little bit, just a discussion about the counseling part. So I saw counseling being done on 2 occasions here, right? So first time when they wanted to do a procedure, which is an informed consent for a procedure, right? And second time they counsel the parents to let them know what the diagnosis is and subsequent things. So let's just talk about the informed consent. Anybody has any feedback on the informed consent that was done here? Any points you want to add on to what they did? They did a good job. You want to add on to something what they did? Sorry, say that again. Okay, right. So as the word says, it's an informed consent, right? That means you need to inform the parents why you're doing this particular procedure. So supposing the parent asks you a question, if this particular procedure has risks, please don't do it. You have anyway started antibiotic for my child. Why do you want to do this procedure? So how will you convince them? And in this case, we anyway diagnosed meningitis, we have given the antibiotic. So if supposing some parent says, no, I'm very scared, please don't poke a needle into the lumbar space, continue the antibiotics and I'm okay. How will you convince? So it's very important for us to convince the parents that this investigation is diagnostic. It is important for us to do it, right? Because if we don't do, we may miss other diagnosis. Maybe it's tubercular meningitis, right? Maybe it's a malignancy which has affected the meninges. So even though the pre-test probability is suggestive of meningitis here, we may still miss out some other causes, and we must have a diagnostic investigation. There must be a clear and a correct label, right? And you have done so many lumbar CSFs, right? All of you must have done as interns. You must have done. So it's a safe procedure, provided you follow all protocols and safety protocols and safety measures. There should be no problem. And this child didn't have any raised ICP. You got an fundoscopy done. There was no papilledema. There are no focal signs. There is nothing to worry about raised ICP. So you can go ahead and do a CSF. In fact, you don't need to do imaging also in this child, because there was nothing like that which kind of said that please get a CT scan done. So therefore, in informed consent, it is important for us to drive home to the parents that this particular test or procedure that we are doing has to be done. There is a need. So therefore, it is important. And then you explain that it's largely safe. Maybe a little, some small minuscule percentage may have complications, but we will take all safety precautions and there should be nothing to worry. And then you will see that once you communicate properly, there should be no problem in getting a consent. The other counseling they did was for the parent after the diagnosis was established. So remember, whenever you do counseling, it's not just that 4 or 5 lines have to be explained to the parents. You just initially make a mental note of what are the things you're going to say. So first important thing you have to say is, this is the diagnosis, right? Second is, this is the treatment. Third, this is the duration of the treatment. Fourth, these are the likely complications we are going to monitor the patient. Fifth, in case unfortunately your child develops some complication, the duration of treatment may increase, right? And the likely hospital duration will be so many days, because they will say, we will go home and take oral tablets. Will you send a meningitis patient home on oral tablets? You won't. So you have to emphasize this point that this has to be an IV medication that has to be given to this patient, right? So the duration of hospital stay will be so many days, and we will keep monitoring for this and this. If the child remains well, then we will possibly discharge on so and so date. So this will be a holistic kind of counseling that you will tell them. And then, like very rightly, the girls asked, do you have any further questions? Because they may have any other questions. So you have given them the opportunity to ask questions to you so that you can discuss out what the issues are. And the last discussion point is the team management or the team dynamics in this particular simulated case scenario. So whenever we are working as a team, there are few points we all need to keep in mind, right? One, there should be a clear team leader. So in this particular case, I think the consultant who came almost was like a team leader here, because he said, you do this, you do this, you do this. So it's not that the others don't know what to do. I'm sure all of them knew that you have to do a lumbar CSF at some point. But when you are in an emergency situation, many times you can't think straight because everybody is working. So you need a clear voice to keep giving you directions. Do this, do this, do this. So we should not take it, "Kya hame nahi pata? Humko kyun bata rahe hai?" It's not like that. That is just to make the team synchronized and coordinated with each other. So there should be a clear voice who should keep telling what to do. Second important thing is there should be discussion between the team. So this is what we call as knowledge sharing. You should keep sharing knowledge. Okay, so this is Koenigs, this is Brudzinski, so this is positive. How do we give position to the patient? What do we explain? So keep talking between the team members, right? Then constructive criticism. If the other team, there were some few occasions where I was noticing one team member was not doing okay, so the other team member was trying to help, but at the same time, I saw that one of them just snatched the mic from one of the team member and started doing it itself. So this is what we call as we should not do it abruptly, but we should do it gently, what we call as constructive criticism. Okay, no, so maybe we should go do this way, so please give, I'll explain, or something like that, right? So knowledge sharing, constructive criticism, having a clear team leader, mutual respect to each other. These are some of the important team elements that you should follow whenever you're working in a team. So this, according to me, is the pyramid. So finally, when we build the pyramid as a clinician, in the history and presenting complaints, we had a very broad kind of a picture. We only knew that there was a CNS or a central nervous system involvement. So we can give a syndromic diagnosis of maybe an acute meningoencephalitis-like presentation. when we started examining the patient, or what we call as a focused examination, we put the next block on this base block. That's because of the neck stiffness. It is pointing that within the CNS, it is the meninges which are involved, right? So we now have what we call as an acute meningitis. We don't know whether it's viral, bacterial, fungal. We don't know anything. We just know that it is possibly an acute meningitis. The third block that we put on this pyramid is, in triage, there was no physiological dysfunction in this child. No respiratory failure, no raised ICP, no CNS, nothing. So it's a physiologically stable child who doesn't require immediate intervention or resuscitation. Then the fourth block we put on this is, we have taken a detailed history. So there doesn't seem to be any underlying comorbidity. We don't have TB, we don't have anything else, no trauma, no ear discharge. So just seems like there is a community acquired meningitis in this particular patient. Then we do the investigation, lab investigation, which is CSF, and that has clearly given you a picture which is suggestive of acute bacterial meningitis. So from acute meningoencephalitis to acute meningitis, now it becomes acute pyogenic meningitis. So again, your pyramid becomes narrow and narrow, and then you give a targeted therapy, which is your ceftriaxone and vancomycin. So this is the process we follow in all patients when you are eliciting history, and then what you are basically trying to do is you are building a pyramid. The base of the pyramid is very broad, non-specific, and very generic. But as you go up with examination and investigation, you become narrower and narrower. And finally, you reach to the tip of the pyramid, which is the etiological diagnosis for the patient. And in this particular patient, it is an acute bacterial meningitis. So this is the case analysis, the analysis of what you have simulated. I think the children have done a brilliant job, the students. I think they deserve another round of applause.
Thank you so much, ma'am, for such a detailed insight on the case discussion. Now, I would like to invite upon the stage Dr. Bhavneet Bhati, Dr. Amarpreet Kaur, and Dr. Jasmine to please come on stage and felicitate Dr. Jayashree.
आई जस्ट वांट टू शेयर वन थिंग. हमारे जब हम 32 में मेडिकल कॉलेज में थे तो एक कंसेंट लेना था. शुरू में तो हम एज रेजिडेंट वी वुड नॉट टेक कंसेंट फॉर lumbar puncture, but now we regularly take consent. So when we started the consent at that time, I was in medical college 32, and there was one father, and I said कि ये consent चाहिए. पूरा explain किया, सारा बताया, और साथ में ये भी बताना पड़ता है कि complications क्या हुई. तो ये दिस इज अ पार्ट ऑफ योर काउंसलिंग दैट यू हैव टू टेल देम. जब हमने बताया कि ये भी प्रॉब्लम है, ये भी हो सकता है, तो उसने कहा मैं तो साइन करना नहीं. सर कि क्यों नहीं साइन करना? कहता तुसी जो करना कर लो, जे कुछ हो गया मेरे फादर ने मैनू छड़ना नहीं. सो द थिंग इज समटाइम्स यू हैव टू अंडरस्टैंड दैट दीज आर कल्चरल थिंग्स. सो आपका पेशेंट बड़ा सिंपल था, सिंपल सारा बात मान रहे थे, पेरेंट्स आपके बड़े अच्छे थे. The difficulty levels could have been little more also. They are not also easy. Asking them, even for the doctor parents, it is very difficult to convince that आपको LP जरूरी है. वो कहना देना है एंटीबायोटिक दे दो 10 दिन, तुसी क्यों LP कराना है? So it's very difficult. But nevertheless, what ma'am said, there is a need to know, and we must do. Only then we can decide whether complication, if there is any other alternative diagnosis, duration of therapies. So all these things are dependent. And CSF is a very vital sample. So I heard that you were talking to the person. Once you do a CSF test, the person should herself or himself deposit that in the lab. We can't do it again. Sometimes we say, gum gaya, idhar gaya, udhar gaya. We have to make sure this is one of the most important samples, and we have to do it, take a personal interest, and also get it within time. Microbiologist and other, they will say, this report has to be, this result has to be, the turnaround time has to be very short. So that also has to be there. Otherwise, the CSF may actually, the cells may lies if you take longer time. Proteins and all still may be there, but we have to make sure that must be done. Okay, thank you.
Uh, uh, I would like to invite Dr. Kamaldeep Singh to please share your insight, and we will be playing the video you just shared. Yes, sir. Why not?
So good afternoon, everybody, and I'm very thankful to the organizers, and especially Madam Principal, for inviting me to this college. And I must say that you are the luckiest few who have joined this college. So ਉਹਦੇ ਬਹੁਤ ਸਾਰੇ ਰੀਜ਼ਨਸ ਹੈ। ਪਹਿਲਾ ਤੇ ਚਲੋ ਮੋਹਾਲੀ ਦੇ ਵਿੱਚ ਹੈ, so you are close to Chandigarh, and even more that you have a very dynamic principal in the form of Dr. Bhavneet Bharti.
Today we are actually writing the institute textbook. We were writing the institutional history, and when I met him there, मुझे पता कि जो project हमारे जब भी हम शुरू करते हैं तो एक detailed project report बनती है. So detailed project report हमारे college की sir ने बनाई थी. So we are very happy that you are able to come and see जो आपने seed लगाया उसको grow करते आप देख रहे हो. So thank you sir. Thank you.
Thank you. ਸੋ ਬੇਟਾ ਕਾਲਜ ਅੱਜ ਤੋਂ 11 ਸਾਲ ਪਹਿਲਾਂ 2014 ਦੇ ਆਸ-ਪਾਸ ਕਨਸੈਪਚੁਅਲਾਈਜ਼ ਕੀਤਾ ਗਿਆ ਸੀ। ਉਸ ਤੋਂ ਬਾਅਦ ਫਿਰ ਪ੍ਰੋਜੈਕਟ ਜਿਹੜਾ ਸੀ ਉਹ ਠੰਡੇ ਬਸਤੇ 'ਚ ਪੈ ਗਿਆ ਵੀ ਨਹੀਂ ਚਲਾਉਣਾ, ਕਿਉਂਕਿ ਮੈਡੀਕਲ ਕਾਲਜ ਚਲਾਉਣ ਦੇ ਲਈ ਬਹੁਤ ਫਾਈਨੈਂਸਿਸ ਲੱਗਦੇ ਨੇ, ਬੜਾ ਇੱਕ ਅੱਛਾ ਹਿਊਮਨ ਰਿਸੋਰਸਿਸ ਚਾਹੀਦੇ ਹੈ। ਸੋ 2017 ਦੇ ਵਿੱਚ ਪ੍ਰੋਸੈਸ ਦੁਬਾਰਾ ਸ਼ੁਰੂ ਕੀਤਾ ਗਿਆ ਤੇ ਇੱਕ ਡਿਟੇਲ ਪ੍ਰੋਜੈਕਟ ਰਿਪੋਰਟ ਜਿਸ ਤਰ੍ਹਾਂ ਮੈਡਮ ਨੇ ਕਿਹਾ ਉਹ ਬਣਾਈ ਗਈ, ਐਂਡ ਇਟ ਵਾਸ ਪ੍ਰੈਜ਼ੈਂਟਡ ਟੂ ਦਾ ਡਾਇਰੈਕਟਰ ਜਨਰਲ ਹੈਲਥ ਸਰਵਿਸਿਜ਼ ਇਨ ਨਿਰਮਾਨ ਭਵਨ ਦਿੱਲੀ। ਉੱਥੋਂ ਫਿਰ ਇਹ ਦੁਬਾਰਾ ਕਾਲਜ ਜਿਹੜਾ ਹੈ ਉਹ ਸ਼ੁਰੂ ਹੋਇਆ। ਇਨੀਸ਼ੀਅਲੀ ਉਹਨਾਂ ਨੇ ਕਿਹਾ ਕਿ ਕਹਿੰਦੇ ਜੀ ਜਿਹੜਾ ਮੋਹਾਲੀ ਹੈ ਉਹ ਤਾਂ ਬਿਲਕੁਲ ਚੰਡੀਗੜ੍ਹ ਦੇ ਨਾਲ ਹੈ, ਉੱਥੇ GMC 32 ਵੀ ਹੈ, PGI ਵੀ ਹੈ, ਸੋ ਮੋਹਾਲੀ ਜਿਹੜਾ ਉਹਨੂੰ ਕਾਲਜ ਨਹੀਂ ਚਾਹੀਦਾ। ਸੋ ਸ਼ਿਫਟਡ ਟੂ ਹੁਸ਼ਿਆਰਪੁਰ। ਜਿਹੜੇ ਜੁਆਇੰਟ ਸੈਕਟਰੀ ਹੈਲਥ ਹੈਗੇ ਸੀ ਉਹਨਾਂ ਨੇ ਕਿਹਾ ਕਿ ਸ਼ਿਫਟਡ ਟੂ ਹੁਸ਼ਿਆਰਪੁਰ, ਮੋਹਾਲੀ ਦੀ ਲੋੜ ਨਹੀਂ ਹੈ। ਅਸੀਂ ਕਿਹਾ ਫਿਰ ਹੁਸ਼ਿਆਰਪੁਰ ਦੇ ਵਿੱਚ ਇੱਕ ਹੋਰ ਖੋਲ੍ਹ ਲਵਾਂਗੇ, ਹੈ ਨਾ, देयर इज़ ऑलवेज ए चांस। सो ਜਿਹੜਾ ਅਸੀਂ ਸ਼ੁਰੂ ਕੀਤਾ ਉਹ ਤਾਂ ਐਟਲੀਸਟ ਕਰ ਦਈਏ। ਸੋ ਇਸ ਹਾਲ ਦੇ ਵਿੱਚ ਮੈਂ 8 ਸਾਲ ਬਾਅਦ ਵਾਪਸ ਆਇਆ। ਇੱਥੇ ਅਸੀਂ ਪਹਿਲੀਆਂ ਅਪਾਇੰਟਮੈਂਟ ਲੈਟਰਸ ਦਿੱਤੀਆਂ ਸੀ, ਫਸਟ ਅਪਾਇੰਟਮੈਂਟ ਲੈਟਰਸ ਇਸ ਜਗ੍ਹਾ ਤੇ ਦਿੱਤੀਆਂ ਸੀ। ਇੱਥੇ ਜਿਹੜਾ ਹੋਸਟਲ ਹੈ ਪਿੱਛੇ ਮੈਂ ਅੱਜ ਅੰਦਰ ਆਇਆ ਤੇ ਇੱਧਰਲੇ ਪਾਸੇ ਹੋਸਟਲ ਸੀਗਾ, ਉਹਦੇ ਸੈਕਿੰਡ ਫਲੋਰ ਦੇ ਉੱਤੇ ਮੇਰਾ ਰੂਮ ਸੀ। ਤੇ ਇੱਧਰ ਪੰਜਾਬ ਹੈਲਥ ਸਿਸਟਮ ਕਾਰਪੋਰੇਸ਼ਨ ਦਾ ਆਫਿਸ ਸੀ, ਉਹਦੇ ਸੈਕਿੰਡ ਫਲੋਰ ਦੇ ਉੱਤੇ ਉਹਨਾਂ ਦੇ ਚੀਫ ਇੰਜੀਨੀਅਰ ਸੀ। ਹੀ ਵਾਜ਼ ਆਲਸੋ ਫਰੋਮ ਅੰਮ੍ਰਿਤਸਰ, ਮਿਸਟਰ ਕਰਨਦੀਪ ਸਿੰਘ ਚਾਹਲ। ਸੋ ਅਸੀਂ ਦੋਵਾਂ ਨੇ ਮਿਲ ਕੇ ਸਾਰੀ ਰਾਤ ਬੈਠ ਕੇ ਪਹਿਲਾਂ ਨਕਸ਼ੇ ਤਿਆਰ ਕੀਤੇ ਕਾਲਜ ਦੇ, ਫਿਰ ਇਕਵਿਪਮੈਂਟਸ ਕਿਹੜੇ ਚਾਹੀਦੇ ਹੈ, ਹਿਊਮਨ ਰਿਸੋਰਸਿਸ ਕੀ ਚਾਹੀਦੇ ਨੇ, ਕੋਸਟ ਅਕਾਊਂਟਿੰਗ ਬੜੀ ਇੰਪੋਰਟੈਂਟ ਸੀ। ਕੋਸਟ ਕਿਸ ਤਰ੍ਹਾਂ, ਕੋਸਟ ਕਟਿੰਗ ਕਿਸ ਤਰ੍ਹਾਂ ਕਰਨੀ ਹੈ, ਕੋਸਟ ਕਿਸ ਤਰ੍ਹਾਂ, ਫਾਈਨੈਂਸਿਸ ਗਵਰਨਮੈਂਟ ਦੇ ਕੋਲ ਤੁਹਾਨੂੰ ਪਤਾ ਹੈ ਹਮੇਸ਼ਾ ਘੱਟ ਹੀ ਹੁੰਦੇ ਹੈ, ਐਂਡ ਮੈਡੀਕਲ ਐਜੂਕੇਸ਼ਨ ਦੇ ਲਈ ਹੋਰ ਘੱਟ ਹੁੰਦੇ ਆ। ਸੋ ਇਹਨਾਂ ਚੀਜ਼ਾਂ ਦੇ ਨਾਲ ਚਲੋ ਅਲਟੀਮੇਟਲੀ ਆਈ ਐਮ ਵੈਰੀ ਹੈਪੀ ਕਿ ਤੁਸੀਂ ਸਾਰੇ ਅੰਡਰ ਦਾ ਲੀਡਰਸ਼ਿਪ ਆਫ ਯੂਰ ਵਿਜ਼ਨਰੀ ਲੀਡਰ ਡਾਕਟਰ ਭਵਨੀਤ ਭਾਰਤੀ ਤੁਸੀਂ ਗਰੋ ਕਰ ਰਹੇ ਹੋ, ਐਂਡ ਆਈ ਹੋਪ ਕਿ ਕਦੀ ਨਾ ਕਦੀ somebody from you get a Nobel Prize.
ਅਸੀਂ ਆਪਣੇ ਕਾਲਜ ਵਿੱਚ ਨਾ ਹਰ ਸਾਲ ਇੱਕ ਮੌਕ ਸੈਰੇਮਨੀ ਕਰਦੇ ਹਾਂ ਨੋਬਲ ਪ੍ਰਾਈਜ਼ ਦੀ, ਐਂਡ ਵੀ ਗਿਵ them the 2024 batch, we give them an award with this hope ਕਿ ਵਿਜ਼ਨ ਇੰਨੀ ਰੱਖਣੀ, we want to have a Nobel Prize, and ਜੇ ਤੁਸੀਂ ਦਿਲੋਂ ਕੱਢਤੀ ਹੈ, I'm ready, that day would be the super day for us ਕਿ ਇੱਥੋਂ ਦੀ ਜਾਣ ਤੇ ਬੱਚੇ ਨਾ ਸੋਚਣ।
ਨਹੀਂ ਮੈਮ, ਤੁਹਾਡੀ ਲੀਡਰਸ਼ਿਪ 'ਚ ਜ਼ਰੂਰ ਲੈਣਗੇ ਜੀ, ਕਿਉਂ ਨਹੀਂ ਲੈਣਗੇ। ਅੱਛਾ ਬੇਟਾ, ਇੱਕ ਨਾ ਜਦੋਂ ਤੁਸੀਂ ਬਾਹਰ ਜਾਓਗੇ ਨਾ, ਦੈਨ ਯੂ ਵਿਲ ਅੰਡਰਸਟੈਂਡ ਵਾਟ ਇਜ਼ ਲੀਡਰਸ਼ਿਪ। ਲੀਡਰਸ਼ਿਪ ਕੀ ਹੁੰਦੀ ਹੈ, ਕਿਸ ਤਰ੍ਹਾਂ ਉਹਦੇ 'ਚ ਕੰਮ ਕਰੀਦਾ ਹੈ, ਰਿਸੋਰਸ ਕੰਸਟ੍ਰੇਂਟ ਜਦੋਂ ਹੁੰਦੇ ਹੋ ਤੁਸੀਂ ਉਦੋਂ ਕਿਸ ਤਰ੍ਹਾਂ ਕੰਮ ਕਰਦੇ ਹੋ, ਇੱਕ ਹਾਈ ਐਂਡ ਕਾਲਜ ਦੇ ਵਿੱਚ ਜਾ ਕੇ, ਇੱਕ ਹਾਈ ਐਂਡ ਹਸਪੀਟਲ ਦੇ ਜਾ ਕੇ ਤੁਸੀਂ ਕਿਸ ਤਰ੍ਹਾਂ ਕੰਮ ਕਰਨਾ ਹੈ। ਸੋ ਦੀਜ਼ ਆਰ ਡਿਫਰੈਂਟ ਥਿੰਗਸ। ਜਦੋਂ ਇੱਕ ਮੈਂ ਵੀ ਆਈ ਐਮ ਇਨ ਗਵਰਨਮੈਂਟ ਮੈਡੀਕਲ ਕਾਲਜ ਅੰਮ੍ਰਿਤਸਰ, ਬਹੁਤ ਪੁਰਾਣਾ ਕਾਲਜ ਹੈ। ਕੁਝ ਸਾਲ ਪਹਿਲਾਂ ਅਸੀਂ ਉਹਦੇ 100 ਸਾਲ ਮਨਾਏ। ਉਹ ਕਾਲਜ ਜਿਹੜਾ ਸੀ ਪਹਿਲਾਂ ਲਾਹੌਰ 'ਚ ਹੁੰਦਾ ਸੀ, ਲਾਹੌਰ ਤੋਂ ਦੈਟ ਕਾਲਜ ਸ਼ਿਫਟਡ ਟੂ ਅੰਮ੍ਰਿਤਸਰ। ਆਲਮੋਸਟ 110 ਸਾਲ ਪੁਰਾਣਾ ਕਾਲਜ ਹੈ। ਈਵਨ PGI ਦੇ ਆਲਮੋਸਟ 10 ਡਾਇਰੈਕਟਰਸ ਦਿੱਤੇ ਨੇ ਉਹਨੇ, ਉਸ ਕਾਲਜ ਨੇ। AIMS ਦੇ 5 ਡਾਇਰੈਕਟਰ ਉਸ ਕਾਲਜ ਨੇ ਦਿੱਤੇ। ਸੋ ਟਾਈਮ ਦੇ ਨਾਲ ਚੀਜ਼ਾਂ ਥੋੜ੍ਹੀਆਂ ਜਿਹੀਆਂ ਚੇਂਜ ਹੋ ਜਾਂਦੀਆਂ। ਸੋ ਇੱਕ ਚੀਜ਼ ਮੈਂ ਤੁਹਾਨੂੰ ਕਹਿਣਾ ਚਾਹੁੰਦਾ, ਜਿਵੇਂ ਇਹ ਦਿਖਾਉਣ ਦੇ ਲਈ ਨਾ, ਇਹਦਾ ਮਕਸਦ ਕੀ ਸੀ। ਸੋ ਉਹਦਾ ਪਰਪਸ ਸੀ ਕਿ ਤੁਸੀਂ ਹਰ ਚੀਜ਼ ਦੇ ਲਈ ਗਵਰਨਮੈਂਟ ਦੇ ਉੱਤੇ ਡਿਪੈਂਡੈਂਟ ਨਹੀਂ ਹੋ ਸਕਦੇ, ਸਟੇਟ ਗਵਰਨਮੈਂਟ ਦੇ ਉੱਤੇ। ਸੋ ਯੂ ਟਰਾਈ ਟੂ ਰਾਈਟ ਦਾ ਪ੍ਰੋਜੈਕਟਸ ਇਨ ਫਿਊਚਰ। ਠੀਕ ਹੈ, ਸੈਕਿੰਡ ਪ੍ਰੋਫ ਦੇ ਵਿੱਚ ICMR ਨੇ STS ਇੱਕ ਸਕੀਮ ਹੈ ਜਿਹਦੇ 'ਚ ਤੁਸੀਂ ਆਪਣੇ ਪ੍ਰੋਜੈਕਟਸ ਲਿਖ ਸਕਦੇ ਹੋ। ਸਟੂਡੈਂਟਸ ਦੇ ਲਈ ਨਾ ਉਹ ਫੰਡਿੰਗ ਕਰਦੇ ਹੈ। ਸੋ ਟਰਾਈ ਟੂ ਰੇਜ਼ ਦਾ ਫੰਡਸ, ਡੋਂਟ ਬੀ ਡਿਪੈਂਡੈਂਟ ਔਨ ਦਾ ਐਗਜ਼ਿਸਟਿੰਗ ਇਨਫਰਾਸਟਰਕਚਰ। ਤੁਸੀਂ ਆਪਣਾ ਇੱਕ ਪ੍ਰੋਜੈਕਟਸ ਲਿਖੋ, ਪ੍ਰੋਜੈਕਟਸ ਤੋਂ ਬਾਅਦ ਉਹ ਜਿਹੜੇ ਪ੍ਰੋਜੈਕਟਸ ਨੇ ਉਹਨਾਂ ਦੇ ਨਾਲ ਟਰਾਈ ਟੂ ਰੇਜ਼ ਦਾ ਫੰਡਸ, try to generate the employment, never try to be the employee only। ਠੀਕ ਹੈ, ਸੋ ਉਹ ਚੀਜ਼ਾਂ ਜੇ ਧਿਆਨ 'ਚ ਰੱਖੋਗੇ, ਅੱਗੇ ਚੱਲੋਗੇ, ਆਪਣੇ ਟੀਚਰਸ ਨੂੰ ਫੋਲੋ ਕਰੋਗੇ, ਜੋ ਮਰਜ਼ੀ ਹੋ ਜਾਏ ਹਮੇਸ਼ਾ ਆਪਣੇ ਟੀਚਰਸ ਦੀ ਰਿਸਪੈਕਟ ਕਰਨਾ। ਸੋ ਇੱਕ ਚੀਜ਼ ਹੈ ਨਾ, always respect your teachers। So again, I am hopeful that you will be very successful, very, very successful in your future, and best wishes to all of you. Thank you.
Now, I would like to invite upon stage Dr. Bhavneet Bhate and Dr. Ritu Garg, HOD, Department of Microbiology, AIMS Mohali, to please felicitate Dr. Kamaldeep Singh. Dr. Kamaldeep, please join us on the stage. Now, I would like to invite upon stage Dr. Amit Sehgal. He's been with us right from the start of the event. Dr. Amit, please join us on the stage. Moving forward to our next role play. Now, the next team is the department which runs a hotel to disinfections, internal medicine with infective endocarditis, to be judged by Dr. Ankur Ahuja. Medicine team, please join us on the stage.
Hello. Hello. Hello.
Hello, good afternoon all. I am Divyansh Kashyap and on the behalf of the Department of Medicine AIMS Mohali, we extend a warm greeting to all present here. Today, we bring you a thought-provoking medical play that murmur of danger. So, let us introduce our cast. We have a patient, Abir, who is an IV drug abuser, his friend Aryan, another patient, Ananya, the senior consultant, Dr. Amrit, a junior consultant, Dr. Gurpreet, a psychiatrist, Dr. Advitya, and a social worker, Ankita, and also Abir's mother, Ankita. Scene 1. Abir was a bright and a dedicated child, always lost in his books and dreams. But when COVID struck, the world around him changed. Classroom closed and friendships changed. And the new faces appeared.
बहुत कूल लग रहा है भाई। ये देख रहा है टैटू भाई। हाँ भाई। अच्छा ये क्या है तेरे हाथ में? भाई बहुत मस्त चीज है। अरे है क्या ये तो बता भाई। तो सही भाई। अरे तो बता तो सही भाई है क्या? भाई बहुत सही चीज है, दिमाग खुल जाता है इससे। अरे नहीं भाई, अरे बहुत गलत सीन हो जाता है। अरे मत कर भाई, मत कर मत कर मत कर। ओए
Under that peer pressure, Abir experimented that thing for the first time. But he didn't knew that one time want will become his habit in future. Abir started noticing some unusual signs. He started developing aches, fever, body aches, and he finally decided to visit to a hospital.
बैठिए, आपका क्या नाम है?
मैम मेरा नाम अबीर।
डॉक्टर साहब मेरे बच्चे को 4-5 दिन से बुखार हो रहा है, इसको बहुत ज्यादा कमजोरी हो गई है, कुछ खा भी नहीं रहा है ये।
बेटा कब से बुखार है?
मैम 4 दिन हो गए मैम, उतर भी नहीं रहा है मैम बुखार। बहुत ठंड लग रही है मैम।
ठंड लग रही है?
हाँ जी मैम।
ये क्या हो रहा है?
ये तो मैम मच्छर काट जाते हैं उसके निशान है मैम।
मच्छर काट जाते
हाँ
हैं?
जी मैम।
ठीक है। अभी आपको पसीना भी बहुत आ रहा है,
हाँ
एक बार
जी,
हाथ दिखाओ। काफी बुखार है?
अभी भी बुखार है इसे।
जी, अभी ना आपके बच्चे को बहुत बुखार है, इसको जैसे पसीना भी आ रहा है, वैसे भी थोड़ा बेचैन लग रहा है। तो अभी हम क्या करते हैं, इनको हम इमरजेंसी में अभी एडमिट कर लेंगे, फिर हम वहाँ पे इनका इलाज शुरू करते हैं। ठीक है? डॉक्टर गुरप्रीत, प्लीज एडमिट हिम इन इमरजेंसी एंड सेंड हिज रूटीन ब्लड सैंपल्स एंड गेट हिज ECG and X-ray done.
He hesitated to tell everything in front of his mother. The doctor, being suspicious, admitted him to the emergency ward, where the junior doctor, Dr. Gurpreet, examined him.
अबीर कैसे हो? भी
बुखार है सर, अभी भी ठंड लग रही है सर, बहुत ठंड लग रही है।
सिस्टर जी, इनका फीवर कितना है?
104 डिग्री फ़ारेनहाइट सर।
ठीक है सिस्टर जी, अभी इनका PCM स्टार्ट किए, मैं आगे की इन्वेस्टिगेशन करूँगा। हाँ जी, अभी आपका नाम, आपका एज कितनी है?
सर मैं 18 साल का हूँ।
18 साल। कहाँ के रहने वाले हो?
सर मैं मोहाली से।
मोहाली। क्या दिक्कत आई आपको?
सर मेरे को 4-5 दिन से सर बुखार है सर, उतर भी नहीं रहा सर, ठंड लग रही है सर, बहुत दर्द भी हो रहा है सर शरीर पे।
कोई गला खराब, सांस लेने में तकलीफ?
नहीं सर।
कोई पेट में दर्द?
नहीं सर।
कोई डायरिया?
नहीं सर।
कोई पेशाब जाने में दिक्कत?
नहीं सर।
कोई परेशानी? ठीक है। कोई कुछ दिन पहले कहीं घूमने वगैरह गए थे आप, कहीं दूसरे शहर वगैरह में?
सर मेरे को खांसी भी है सर, खांसी है सर।
खांसी है? कोई दूसरे शहर में घूमने वगैरह गए थे?
नहीं सर।
कहीं नहीं घूमने गए। अच्छा, कोई और दिक्कत परेशानी पहले आपको कोई दिक्कत हो पहले की?
नहीं सर।
कोई दिक्कत नहीं। कोई नशा वगैरह करते हो, कोई दारू सिगरेट?
नहीं नहीं सर, नहीं कुछ भी नहीं।
कुछ भी नहीं। ठीक है। अच्छा, मैं अभी आपकी जांच करूंगा। ठीक है, चश्मा हटा लीजिए। नीचे देखो, गर्दन सीधी करो। ये क्या बना हुआ है हाथ पे? ये क्या बनवाया हुआ आपने?
सर ये मैंने मेरे दोस्त के साथ जाके टैटू बनवाए थे।
टैटू? और ये निशान कैसे हैं?
ये तो सर वो मच्छर काट जाते हैं ना, बहुत सारे हैं सर, देखो हमारे उधर मच्छर बहुत है।
अच्छा, मच्छर। ये मच्छर वाले निशान लग रहे, कोई नशा वगैरह तो नहीं करते आप?
मच्छर ही है, मच्छर ही है, मच्छर है सर, बहुत मच्छर है सर हमारे उधर।
The junior doctor observed unusual marks on the Abir's body.
Good morning. So, Abir's admitted?
Yes, ma'am.
Please brief me about his case.
All right, ma'am. Abir, he's a 18 years old male, presented to emergency with chief complaints of fever. Currently, he's a fever under evaluation. On examination, I found it splenomegaly, lymphadenopathy, and splenomegaly. On X-ray findings, And though after routine investigation, there was X-ray finding an ECG showing tachycardia, and X-rays showing infiltration in the right middle lobe of the. Ma'am, on examination on the forearm, there are tattoo marks and multiple puncture marks suggestive of patient being the IV drug abuser, but patient has no significant history given.
ओके बेटा अपने हाथ दिखाओ गुरप्रीत हैव यू नोटिस these are oscillus nodes. These are nodular structure with painful nodular structures on the tips of hands. So these are the oscillus nodes. बेटा अपने हाथ ऐसे show your nails अपने नाखून दिखाओ ये दिख रहे हैं आपको red ये these are splinter hemorrhages. बेटा ऐसे दिखाओ ये आपके ये कैसे हुए ये निशान
ये मैम मच्छर वगैरह काट जाते हैं ना उसके कारण है
ये मच्छर जैसे बेटा ये लग नहीं रहे हैं
नहीं मैम मच्छर ही हैं मैम बहुत मच्छर है हमारे वो बड़े मच्छर हैं मैम
बेटा देखो अभी आपकी मम्मा नहीं है यहाँ पे साइड बाहर भेजा है तो आप मेरे को सच सच बताओ दिक्कत हो सकती है अगर आपने झूठ बोला तो आप नशे तो नहीं करते हो
हाँ मैम
कब से करते हो
मैम काफी टाइम हो गया मैम
काफी टाइम हो गया एंड एनी अदर फाइंडिंग्स ऑन ऑस्कल्टेशन
ऑस्कल्टेशन में उनके ट्राइकस्पिडिया में मरमर जैसा कुछ फील हो रहा है एक बार आप कंफर्म कर लीजिए
यस डॉक्टर गुरप्रीत यू आर राइट इनके टीआर है ट्राइकस्पिड मर्मर है सो वी हैव अ पेशेंट 17-year-old male who has come with a history of fever for 4 days. The history was he is having high grade fever, and on examination we have found that there are IV drug marks and oscillus nodes and splinter hemorrhages are present on his hand, and there is lymphadenopathy and the splenomegaly. And on ECG we have found tachycardia, and in chest we had found there are infiltrates in the right middle lobe. So according to these findings, clinically we suspect this patient to be of right-sided bacterial endocarditis. So now, Dr. Gurpreet, we will start his empirical treatment. But first, send his blood cultures. We have to send 3 blood cultures from different venous sites and at the gap of 30 minutes. And then start him on vancomycin and ceftriaxone empirically and get his echo done.
ओके मैम
मैम मम्मी को मत बताना मैम नशे का
बेटा बताना तो पड़ेगा
The senior was calm and wise and asked for the cultures with keen and sharp eyes. Then the lab technician, the nurse, arrived for taking the blood samples.
मैं लैब से आई हूँ बच्चे आपका नाम अबीर है
हाँ जी मैम
आपके साथ कोई आया है बच्चे
हाँ जी मैम मेरी मदर है मैम
अच्छा आप इनके मम्मा हो देखिए हमें इनके ब्लड सैंपल्स भेजने हैं हर आधे घंटे के बाद इनके 3 ब्लड सैंपल्स जाने हैं ठीक है जी तो मैं इनका सैंपल ले सकती हूँ ठीक है
She is taking all the precautions that is needed. On the same day in the medicine ward, we have another patient.
हेलो धन्या जी कैसे हैं आप
बिल्कुल ठीक नहीं लग रहा मैडम
आपके यहाँ पे दांत में दर्द है
हाँ जी सूजन भी आई हुई है
So similarly, we also had a patient in our ward. She came 2 weeks back with a history of fever for 2 weeks. Her fever was of intermittent type and she had dental implants 2 weeks back. there is no pain and swelling in her lower jaw, but and there was no history of any cardiac anomaly. But on her investigations, when she was being evaluated for the fever for the past 2 weeks, then we found that in echocardiography there was aortic valve anomaly, bicuspid aortic valve anomaly, and there was vegetation on her aortic valve. The cultures, when it was done, there was streptococcus viridans. So while this treatment period, we had started her on ceftriaxone, and now she's being monitored for her fever and 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 is recovering well.
Now, 30 minutes later, it's the time for the second blood culture.
बच्चे अभी आधे घंटे हो गए तो मैंने वापस से सैंपल लेना है आपका, ठीक है?
आप कितनी बार सैंपल लोगे, कितने बार इसका खून लोगे? इसके शरीर में तो बिल्कुल भी खून नहीं बचा है, क्यों ले रहे हो बार बार आप?
देखिए, आप घबराइए नहीं, ये प्रोसीजर है नॉर्मल। हमें 3 बार सैंपल लेना होता है, जैसे मैंने बताया था, हर आधे घंटे बाद इसका सैंपल जाएगा। उसके हिसाब से फिर डॉक्टर आगे की दवाइयाँ शुरू करेंगे। अगर कुछ भी है तो मैं डॉक्टर गुरप्रीत से बोल देती हूँ, आपसे बात कर लेंगे, ठीक है जी? मैं इनका सैंपल ले लूँ फिर? ओके।
ठीक है, आपको जो परेशानी मैं आपको समझाता हूँ। देखिए, आपका जो भी बच्चे की हालत है वो थोड़ी सी नाजुक है। हमने उसकी ट्रीटमेंट शुरू कर दिया बच्चे का। आपका बच्चा जो है ना नशा करता है, आईवी से इंजेक्शन से नशा करता है आपका बच्चा। तो क्या हुआ?
नहीं, मेरा बेटा इंजेक्शन नहीं, नशा नहीं कर सकता, वो नशा नहीं करता, बहुत इंटेलिजेंट बच्चा है। कभी रात को बाहर नहीं गया, कभी कुछ उसकी संगत भी मैंने कभी ऐसे नहीं देखी। नहीं, वो नशा नहीं कर सकता है वो।
देखिए, समझने की कोशिश कीजिए। हमने बच्चे की जांच की है। अभी जो बच्चे को बीमारी हुई है, बच्चे के दिल में इन्फेक्शन आया।
दिल में मेरा बच्चा बच जाएगा अभी, उसको तो सिर्फ बुखार था।
जी, घबराइए मत, हम पूरी कोशिश कर रहे हैं आपके बच्चे को बचाने की। बच्चे के दिल में इन्फेक्शन है। बच्चा जो जिस नीडल से बार-बार नशा लेता था, वो इन्फेक्शन अपनी वेन से फैल के दिल तक पहुँच चुकी है। अभी जो हम जाँच कर रहे हैं बच्चे की, बार-बार इसी कारण जाँच कर रहे हैं कि हमको और जो उसकी कॉम्प्लिकेशन है और केस आगे ना बिगड़ जाए। बिगड़ क्या सकता है बच्चे की बच्चे को आगे जाके साँस लेने में तकलीफ हो सकती है। इसलिए हम बार-बार सैंपल ले रहे हैं। आपका बच्चा ठीक होने करने की
आप
पूरी
बस
कोशिश
मेरे
करेंगे।
बच्चे को ठीक कर दो, जो मर्जी करना है, जैसे ट्रीटमेंट करना है, मेरे बच्चे को ठीक कर दो।
जी, हम पूरी कोशिश कर रहे हैं।
Now, Abir started feeling restlessness. He showed symptoms of withdrawal.
डॉक्टर साहब, डॉक्टर देखिए मेरे बेटे को क्या हो गया। कल से लेके आए थे तो इसको सिर्फ फीवर था, अब इसे क्या हो रहा है? ये देखो, ये ऐसे क्यों कर रहा है?
क्या हो रहा है आपको?
सर पैरों में बहुत दर्द हो रहा है सर, लातें टूट रही हैं सर, ठंड लग रही है सर बहुत देर की, बेचैनी भी हो रही है सर।
As the patient is going into withdrawal symptoms, we will call for an advice for a psychiatric opinion for this patient.
Now, in the next scene, we have our psychiatrist, Dr. Advitya, and she brings a counselor with her.
हेलो, मेरा नाम डॉक्टर अद्वित है। हम मनोरोग विभाग से हैं। आप कैसे हो अभी? आपको क्या दिक्कत आ रही है?
ठंड लग रही है मैम, पैरों में दर्द हो रहा है मैम, सारी लातें टूट रही है मैम, घबराहट हो रही है मैम। मैम मेरे को टीका ला दो मैम।
नहीं नहीं, आप शांत हो जाओ।
मैम मेरा दोस्त है मैम आर्यन, उसको बुला दो मैम, वो ला देगा मैम। मैम वो नहीं होगा मैम, उसको कह दो आप, वो टीका ला देगा मैम।
आप नशा टीके लगा के करते थे? तो आप कब से लगा रहे हो टीके?
मैम काफी टाइम हो गया।
कितना टाइम हो गया? कितनी
मैम,
बार लगाते थे?
याद नहीं है मैम, पर दिन में एक बार लगा लेता था मैम।
तो आपने आखिरी बार टीका कब लगाया था?
एक दिन हो गया मैम।
अभी आप शांत रहिए, हम आपको दवाई लिख के देंगे।
नहीं मैम, आप टीका ला दो मैम।
टेंशन की कोई बात नहीं है, आप शांत हो जाओ, हम आपको दवाई लिख कर दे देंगे।
मैम मेरा शरीर बहुत टूट रहा है मैम, आप टीका ला दो मैम।
उसी के लिए दवाई आपको जब भी ऐसा लगे, आप वो दवाई गोली जीभ के नीचे रख सकते हो। उससे आपकी परेशानी कम हो जाएगी। अगर आपको फिर भी लगता है कि परेशानी कम नहीं हो रही है या कुछ और दिक्कत आ रही है, तो आप बिना हेजिटेट करे हमें बता सकते हो।
ठीक है।
Now, the counselor explains the patient's mother.
दवाई दे दी ना।
मैं काउंसलर हूँ। सुनिए, देखिए आपके बेटे को जो बीमारी है ना, उसका मुख्य कारण है कि वो ना जो ड्रग्स लेता था ना, वो आईवी इंजेक्शन के थ्रू लेता था। ठीक है, तो देखिए आपका ना इसमें मुख्य रोल है कि आपको ना उसे अब ना जो है देखना, ध्यान देना है कि वो ऐसी ड्रग्स ना ले, ऐसे आईवी इंजेक्शंस ना ले, और उसे ये एहसास दिलाना है कि आप सब उसके साथ हो, अकेला नहीं है, उसका परिवार उसके साथ है। ठीक है, और अगली बार वो अगर ऐसा कुछ लगे आपको कि वो गलत संगति में पड़ रहा है या वापस से ऐसे ड्रग्स ले रहा है, तो तुरंत जाके अपने डॉक्टर से मिलिए और या तो हमारे पास आ जाइए। ठीक है, ठीक है, ठीक है।
Next, day 3. The investigation reports arrive.
Dr. Gurpreet, we have his cultures and eco report now?
यस मैम, इको रिपोर्ट्स आर अवेलेबल। एज पर इको इनके जो ट्राइकोस्पिड एरिया में वेजिटेशन दिख रहा है, और जो हमारे पास कल्चर रिपोर्ट्स है, कल्चर रिपोर्ट में इनका स्टेप्टोकॉकस ऑरियस, स्टेफाइलोकोकस ऑरियस आ रहा है, विच इज सेंसिटिव टू वैनकोमाइसिन।
So now we have his eco reports, which are positive with the culture, with vegetations in the tricuspid valve, and then we have his blood culture, which was positive for Staphylococcus aureus. So now, Dr. Gurpreet, start him on the targeted therapy, put him on vancomycin, and repeat his cultures until they come sterile. अभी अब कैसा लग रहा है?
मैम पहले से फर्क है मैम थोड़ा।
वैसे बेचैनी वगैरह वो ठीक है अब?
हाँ मैम, वो उन्होंने कुछ गोली दी मैम, उसके बाद।
हाँ, अब देखिए, हमें ऐसा, ये जो बीमारी है ये वापस हो सकती है। इसमें हमें क्या है कि अगर ऐसे ये अभी अगर ठीक हुआ है, इसका ट्रीटमेंट पूरा 6 हफ्तों का है। हमें इसे पूरा ट्रीटमेंट देना पड़ेगा, उतना टाइम हमें यहाँ पे रखना पड़ेगा इसे, ताकि ये बीमारी फिर ना हो जाए।
अब बस इसे बिल्कुल ठीक कर दीजिए।
जी।
After 2 weeks, the patient health is improving as the fever has subsided, and repeated chest X-ray, ECG, and echo were convincing in the progress of prognosis. Now, next, he was called for a follow-up. The treatment was given for 6 days, following which the patient was discharged, and the patient came to the OPD after 1 week and asked about his addictions.
So after discharging him after the treatment of 6 weeks, then we have called him on follow up. So then now our patient has recovered because he has completed his treatment course, and his de-addiction is also going well. So here we have presented 2 cases. One is 18-year-old male with a history of IV drug abuse, and second patient was 45-year-old female Ananya, who had her dental implant. So these two were the risk factors which caused the injury to the heart. Now, in Abir's case, we had right-sided in acute infective endocarditis. This was because of Staph aureus going into right side circulation first, and whereas in Ananya's case, we have left-sided subacute infective endocarditis because her dental implant went into the left circulation. The bacteria from there went into the left circulation. Then we did blood cultures for both of them. Staph was positive for Abir and Strepto was positive for Ananya. Streptococcus was positive for Ananya. Then on eco findings, we found a heart anomaly in her case, which was the major cause of her disease, and IV drug abuse was the cause of his disease. And then after following the treatment of 4 weeks, Ananya was discharged, and Abir was discharged after the treatment of 6 weeks. Thank you.
From drug to tooth, the link we have seen. Prevention's better. Keep your bloodstream clean. Thank you so much.
Thank you, Team Medicine, for such an insightful play. Now, I would like to invite upon stage Dr. Ankur Ahuja for the case discussion.
Yeah, hi. Good afternoon. I must say there were two very interesting cases. Not very commonly you see two different kind of infective endocarditis in your practice. So first is, if you could just excuse me, can I call the mother of the patient here on the stage? I must say she's an amazing actress. Now, I could say, I hope she turns out to be as good a doctor as she is an actress. Right. Okay. So there are certain things which I'd like to point it out. As a cardiologist, we are not very frequently called up to see the patient directly because of fever. More often than not, we'll be called up when a patient is being evaluated for fever. Something turns up. More often than not, it would be you have a PUO, which you call as fever of unknown origin, and the patient is being evaluated. Echo has been done. You see a vegetation, and then we are called for opinion. But certain things I must tell you. The first patient, other than the IV drug abuser lady that she came up, you saw that it's a case of SABE, subacute bacterial endocarditis, where patient had a dental implant, and because of that bacteremia, it involved her one of the valves. But generally, what you will see is native valves, if they are normal, it's not very common to see they're getting infected. It's more often than not, people would have some congenital anomaly, rheumatic heart disease, something like that. They are more prone to getting an infection on the valve and they get involved. It's very important, once you have seen a patient of SABE, you have diagnosed, the person has some kind of infective endocarditis, has been treated for that. It's our duty to tell that whenever she gets a further orodental procedure, she gets antibiotic prophylaxis, which was missing in this case. It's our duty to tell the patient, you had an infective endocarditis episode, you should abstain, or you should, once you are getting a orodental procedure, please take care that you tell the dentist you need to get an antibiotic prophylaxis for that. So this was something which was very important and should be told to the patient. IV drug abusers, I have never seen an IV drug abuser who comes and tells me I take IV drugs. So it's always you have to see. So more often than not, we will see a echo finding, whereas a right side infective endocarditis is there. You see a vegetation on the tricuspid valve, and you then leadingly ask the patient, do you take? More often than not, patient would still deny that. One of the family members or the friends would come and tell you that this or so and so patient is a IV drug abuser. Because unfortunately, whatever IV drug abusers I have seen in the past, none of them has given me the history for IV drug abuse. And you see the epidemiology or the bacterial strain are different in both the scenarios. Oral streptococci, they go and infect, they are little less virulent, they cause an indolent infection, which takes some time to present itself. For IV drug abusers, more often than not, it's a staph, which is a very virulent organism. Patient presents very early, is very sick. In our scenario, what we saw is patient is coming and telling you the history very comfortably. But more often than not, patient would be going into some kind of complications. Patient would be very sick, may be hemodynamically unstable, may not be able to give you history himself. So you have to leadingly ask. Second thing is, what I saw is there was a lung patch which was not evaluated further. Could anyone tell me what was the lung patch, the reason for the lung patch? Nobody evaluated for that. So there has to be a reason. So was it pneumonia? What do we feel? It could be a septic infarct, or it could be an abscess also. So you need to be aware that the patient has been dealt and explained and observed for those phenomena, because sooner or later, once a patient comes in your follow-up, if you keep on seeing that patch or that patch is resolved, we saw that they told us on the X-ray the patch was resolved. So probably that was an infarct or abscess which resolved over a period of time, and that can be a source of problem or confusion in the future. There's certain other things. consent part, I think a lot of points have been covered by Dr. Joshi for the consent and everything, which I'll not dwell on again. But there, one more point. Yeah. So that was the duty of the doctor to tell you, explain to the patient rather than the phlebotomist telling the patient. Why do we need to take it? Anybody? Case presenting team. Why do we need to take 3 samples? So why is it a criteria? So again, it's the related to that. In infective endocarditis, the bacteremia is almost always persistent. So the criteria goes is if you have a very typical organism for bacteremia or infective endocarditis, if 2 of the 3 culture sets are positive, you take them as okay. But if it is a related organism which can cause infective endocarditis, but not very typical. So certain organisms are very typical, such as staph and strepto, which we talked about. But there could be other organisms which can cause infective endocarditis. But in those situations, all the cultures should be positive. If three cultures have been taken, all the 3, or if 4 cultures have been taken, majority of them, 3 or 4 of them. So because infective endocarditis is related with persistent bacteremia. So it's a doctor's duty before the phlebotomist comes and tells the patient, why are we taking 3 cultures? 3, sometimes we can take more cultures, but minimum is 3. I think that should be it on my side, but I must say it's a very good presentation. Thank you.
Now I would like to call upon stage Dr. Bhavneet Bhati, Dr. Baldeep and Dr. Kiran to please come on stage and felicitate Dr. Ankur Ahuja. Dr. Ankur, please join us on the stage. With every clean cut lurks a microbe yearning to dwell. Before the site swells, Department of Surgery, it's your turn. Please come on stage for the surgical site infections to be judged by Dr. Anupam Goel.
A very good afternoon to all. Hospitals, where healing is the mission, can sometimes become unintended breeding grounds for infection. We are going to depict a skit showing the same. Now, in scene one, it is a busy afternoon in the surgery ward where Dr. Pragya is here on her rounds. She's checking on her patients, assessing their charts, and doing necessary examinations. Let us observe her closely.
डॉक्टर सान्या स्टाफ चलो पेशेंट राउंड पे चलना है क्या है इस पेशेंट को बताओ
Ma'am, this is the patient of diabetic foot on conservative treatment.
ठीक हो आप बुखार आ रहा है
हाँ जी
अच्छा और दवाई ले रहे हो
हाँ जी ले रही हूँ
कितना रह रहा है बुखार
100 से ऊपर ही रह रहा है
अच्छा और पैर में ज्यादा दर्द हो रही है
हाँ जी
दवाई से ठीक नहीं हो रहा
नहीं जब लेती हूँ
इनकी आईवी एंटीबायोटिक्स वगैरह चल रही है ना सब अच्छा एक बार वूंड खोल के दिखाओ ओहो इसमें तो बहुत ज्यादा पस आ गई है इसके इंसिजन लगा के पस ड्रेनेज कीजिए
ओके मैम
बताइए
Ma'am, this is the patient of mesh hernioplasty, midline incision on post-operative day 1.
हाँ जी कैसा फील कर रहे हो आप
मैम थोड़ा दर्द हो रहा है पेट में
बुखार तो नहीं आ रहा
नहीं बुखार नहीं आ रहा
अच्छा दिखाइए ये देखिए अरे आपका तो बहुत बढ़िया ऑपरेशन हुआ है बहुत महंगी वाली जाली लगी है
अच्छा
आपको अगले दिन ही छुट्टी मिल जाएगी
अच्छा आ मेरा पेट बहुत दुख रहा है मेरा पेट बहुत दुख रहा है
क्या हुआ इतना शोर क्यों कर रहे हो आप डॉक्टर डॉक्टर देखिए क्या हुआ पेशेंट को
क्या हुआ साक्षी क्या हुआ
पेट दुख रहा है मेरे पेट में से पानी निकल रहा है देखो मुझे बुखार है आपने कैसा ऑपरेशन किया है
अरे
आपने
चिल्लाओ
महंगी
मत
वाली
चिल्लाओ
जाली
मत
बोली थी
कोई
लगाने
नहीं
को।
कुछ नहीं होता दिखाओ अपना पेट दिखाओ
देखो आप
खोलिए थोड़ी सी इन्फेक्शन है कोई नहीं इनको आईवी एंटीबायोटिक सारी दवाइयां इनकी चलाते रहो ठीक है घबराओ मत ठीक हो जाएगा
आपने बोला था महंगी वाली डाली है
कुछ नहीं होता
Now, let us see the conversation between healthcare staff reflecting upon this incident.
क्या कर दिया इनको क्या हो गया ऐसा कैसे हो गया इनके इतना इन्फेक्शन कैसे हो सकता है अभी तो हम देख के गए थे इनकी सर्जरी इतनी अच्छी हुई है
मैम आपने तो जैसे बोला था हमने वैसे ही इंजेक्शन एंटीबायोटिक सब टाइम टू टाइम मैंने दिया था
मैम मैंने तो ड्रेसिंग भी सही से की थी एसेप्टिक तरीके से और
कैसे हो गया फिर ये
मैम मैंने तो 2 बार ग्लव्स चेंज किए थे अब मैं क्या बताऊँ इसमें
नहीं तो इतना इन्फेक्शन कैसे हो सकता है मुझे बताओ
मैम शायद आप सीनियर
बोलो क्या हो गया
मैम इफ़ यू डोंट माइंड कैन आई से समथिंग
बोलो
मैम एक्चुअली मुझे लगता है जब आपने डायबिटिक फुट के पेशेंट को हाथ लगाया था और फिर उसके बाद जाके आपने इस पेशेंट को हाथ लगाया था और आपने ग्लव्स भी नहीं पहने थे शायद
नहीं ऐसा कुछ नहीं हुआ है
आई थिंक सो
मैम शायद उस दिन आपने ग्लव्स नहीं डाले थे
ऐसे कैसे बोल सकते हो तुम चलो जो गलती हो गई अगली बार नहीं होना चाहिए चलो
ठीक है मैम
As we can see, that once a well operated patient has now developed a surgical site infection. This shows the harsh reality of hospital acquired infections. Owing to the busy hours, heavy patient load, we often neglect the importance of hand hygiene. And this one mistake can be devastating for the patient. I would like to conclude by saying that before pointing fingers, make sure your hands are clean. Thank you.
I would like to invite upon stage Dr. Anupam Goyal to please hold the case discussion.
Good afternoon. So I would say a very short and brief play by the surgery department. And I always tell my juniors or colleague that when we operate, when we do surgery, we always create a humor. कि जब भी आपने पेशेंट को अगले दिन मिलना है, आप थोड़ा सा एक उसे एक ऐसी चीज बोलिए जिससे उसके फेस पे स्माइल आए. सो आई वाज हैप्पी टू सी कि हमारी जो टीम है ये काफी कॉमेडी यहाँ प्रोड्यूस कर रही थी. एंड इसमें कुछ लेसन्स हैं जो हमने समझना है. So first is the communication. Actually, when you see a patient on day one, the communication of the consultant is very important by the patient. So जैसे इस प्ले में हमने बताया कि आपका ऑपरेशन बहुत ठीक हो गया है, आपकी ये मैश डली है. So these are very sensitive actually statements because no surgery is complete on day one. So it is not completed till a patient say मैं डॉक्टर साहब बिल्कुल अच्छा फील कर रहा हूँ. It could be 1 week, 2 weeks, 1 month even. So you should not come to a conclusion on day one कि आपका सब बहुत बढ़िया हो गया because surgery is all about आप सर्जरी करके आ जाते हैं, उसका रिजल्ट आपको हफ्ते 2 हफ्ते 4 हफ्ते के बाद मिलता है, राइट. और सेकंड इज योर क्लिनिकल जजमेंट कि जब भी आप पेशेंट को डे वन पे देखते हैं, योर दैट जजमेंट शुड बी वेरी वेरी ब्रीफ. कि I always say that surgery में 99% of times you would know that what you have done in the surgery and how the outcome would be, but that 1% comes on the day one. Because अगर आपने पेशेंट के पल्स को हाथ लगा के नहीं देखा क्या टेकिकार्डिया है, पेशेंट का फीवर चेक किया कि नहीं किया, बीपी, इज देयर एनी हाइपोटेंशन, कोई सेप्सिस का कोई साइन है. So there are different reasons of sepsis which you can actually find on day one, and you can correct. If you take a corrective measure early, your patient will go home well, right? And lastly, I would say empathy. Always have a empathy for your patients. Always feel that you are operating on your relative. Always feel you are operating uh, in a auditorium. Like if you are operating, everybody is seeing you, so that you always give the best in that patient. सो लास्टली जो एक चीज मेरे को बहुत अच्छी लगी, दैट वाज अ ओपन माइंडेड टीम because we were trained in department where we cannot say anything to our bosses, like they were the Hitler type bosses. So yes, the trend is changing where you can interact well with your bosses. Surgery is all about doing a work and then discussing your own demerits कि आप कहाँ गलत हैं. So well done team surgery. And how many of you want to be a surgeon actually, because you are undergoing MBBS and you are looking for medical branches, surgical branches? 1, 2, 3, 4, 5. So it is actually less than 2%, I would say. So yeah, so why others don't want to be a surgeon? Just a common answer क्या होगा सभी का? It's a difficult branch. It has a long career, right? So, but I would say this is not the notion. When you will go to internship, you will realize that you are a medicine person or you are a surgery person, because sometimes you would love seeing the blood, you would love doing something with your hand, right? So always attend your clinical assessments very well, because this is the time you will realize which branch you want to do. It is not the rank which you would decide. जिन बच्चों ने आज सर्जरी के लिए हाथ उठाया है, अगर ये सर्जन बनेंगे, bet me they would be the best surgeon in the city or best surgeon in the nation. Thank you.
For the last case presentation on ventilator associated pneumonia to be judged by Dr. Deepika Gupta, well, ICU. Please welcome our anesthesia team on the stage.
ਸਾਡੀ ਸਲਾਈਡ ਸੀਗੀ ਉਹ ਤਾਂ ਕੱਢ ਕੇ ਕਿੱਥੇ ਆ ਹਾਂ ਉਹ ਕਹਿ ਰਹੇ ਨੇ ਤੇ ਪੀਪੀਟੀ ਤਾਂ ਲਾ ਦੇ ਅੰਦਰ
ये मेरा अकाउंट है नहीं है
पीपीटी
पीपीटी लगा दो इनकी इतनी देर क्या गिरा माइक In the meanwhile, I would like to invite Dr. Bhavneet Bharti, Dr. Vivek Pahuja, and Dr. Anupam Goel. Please come on stage for the felicitation. ये उस पे आई हुई है एम्स प्रेजेंटेशन पे
So we are doing an infectious diseases fest, and in which we have involved lots of. Sir, ਇੱਥੇ ਬੈਠੋ ਮਧੁਕਰ ਜੀ, just sit here. So as we said, the bug quest and the various types of microbes, and we all cannot fight the infections by ourselves. And one of the infections, being a pediatrician, and was polio. All of us have seen. For you, it's a history now. I don't think so you have seen a case of polio. So we used to see so many cases of polio, and the partners, the biggest partners for the eradication of polio, almost eradication, 99% cases have already been eradicated. There are only 2 countries currently in the world where it is still endemic, and that's Pakistan and Afghanistan. And we have eradicated polio. But in that journey, one of the biggest partners were Rotary, the Rotary International, and we have the president of the Rotary Club Chandigarh and the past district governor, Mr. Madhukar Ulaka. So we said that on this day, 24th October is celebrated as the World Polio Day, and for this historic occasion, we felt that they should be present here. So we already have a board made outside. We're talking. With your help, we'll be able to complete this target of ending the polio in the world. If it is there in 2 countries, it's still a threat. So we cannot allow that to happen. And Madhukarji, if you can speak for 2 minutes. Because the journey, how he has done and how it was done, it's almost 35 years.
Yeah. Hello. I'm from the Rotary Club of Chandigarh. In early, I think it was something like 78 or 79, that Philippines, one of the directors of Rotary International belonged to Philippines, and he decided, like we do normally, Rotary में service projects करते हैं, to immunize every child in Philippines in a certain period time span. I mean, he fixed 2 Sundays and said, let every child be done. And the result was that next year, the number of polio cases were down by 95%. And that shook up, Philippines, Rotary, and Rotary International approached WHO to take it up as an international project. And they said, no, we can't accept because we were not there and it is not documented properly by our standards. So I think the next one was either Tajikistan or, Kazakhstan, one of the two, where again a similar experiment was done and it worked beautifully. Then Rotary decided to take up polio eradication as a program worldwide. In 1985, we were also told कि polio के लिए करना है. So we would carry our, umbrellas and tables and chairs and medicine, and then start giving 2 drops wherever, the medicine was supplied by Rotary International. Government of India was not involved. Unfortunately, the government of India just would not accept that polio can be eradicated in India. They said, India, it is next to impossible. We can't do it. WHO said, अगर इंडिया में खत्म हो गया तो दुनिया में खत्म हो जाएगा. So you're making an attempt, that's good. So 85 to, I think it was Inder Gujral became the Prime Minister of India, and he was a former Rotarian functionary. With his becoming the Prime Minister, we could approach him as a Rotarian, as a countrywide project, and he agreed. Even after his agreement, the government machinery, the way it works, didn't start at all till Mr. Narasimha Rao became the Prime Minister of the country, and he made it a national program, and thereafter the rest is history. Fortunately for me, in 2010-11, I was the governor of Rotary District 3080, and we had a problem area in Saharanpur where about 500-600 families refused to give polio vaccine, and that was the last area where we would get a case or two once in a while. Finally, luckily, a colleague of mine, a Rotarian colleague of mine from Malerkotla, he was a Muslim himself, he said, "You're going about the wrong way. Don't take doctors, don't take anybody. Take a Hakims and Muftis with you." And I said, "How will we do that?" He said, "Let me join you." So we went there. So हम उसके साथ ऐसे गए जैसे हम अंडरस्टडी हैं और ये हमें सिखा रहे हैं. It worked. All 500 families agreed to take the polio vaccine, and rest is history. In 2011 January was the last case of polio in India, and India has been free ever since. And like ma'am said कि polio दो countries में है. Well, it respects no boundaries. Any child coming, anybody coming with a polio infection can give us infection. आजकल तो बंद है, कोई ज़्यादा travel होता नहीं है, but that is a problem. I think Afghanistan and Pakistan, there again the rigidity comes from the the muftis and all that, and they say that हमको important बनाने की कोशिश कर रहे हैं and all that. But I hope it will come, because I think there are just 10 cases now in Pakistan and about 6 in Afghanistan. That's all that is left now. So we are keeping our fingers crossed. When Rotary took up this project, they thought it'll be a couple of $1 million that we'll spend. Finally, Rotary itself has spent nearly $9 to $10 billion on this. And it all comes from voluntary donations from Rotarians and, of course, their contacts all over the world. Thank you so much. I might have taken a little more time.
Thank you, sir. Thank you for coming. And thank you, Abaji, for coming. This is obviously a historic occasion. And we thought we must not forget what Rotary has done for this disease. Thank you. Thank you.
Before we start with the ventilator-associated pneumonia, I would like to take a moment of everyone's attention to welcome our special guest, Dr. V. Ramasubramaniam, Senior Consultant, Department of Infectious Disease and Tropical Medicine, Apollo, Chennai. Please welcome him with a huge round of applause.
Hello, 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 hello.
I would also like to introduce our other special guest, Dr. Madhumita Ramabhadran, Senior Consultant, Department of Infectious Disease and Infection Control, MGM Healthcare, Chennai. Please welcome her with a huge round of applause.
जितना कम दिखेगा उतना कम वो सही है। जरूर स्लाइड चेंज करानी है ऐसे टाइप कर लेंगे। निकलेगा वो थोड़ी हो लगेगी अजीब।
Sorry for the delays. मैंने क्या जाओ तो वो
तेरी स्टार्ट है ना
आगे बढ़ दो ना यार। In the intensive care unit, every breath counts. Machines beep, monitors blink, and behind every ventilator is a story, a patient fighting for life. But sometimes, despite all the cares, stubborn unseen microbes find their way in, leading to one of the most feared hospital acquired infections, that is, ventilator associated pneumonia. So, good afternoon, all. I am Komal from BAT 2022. On the behalf of Department of Anesthesia and Critical Care, along with my team, will take you all through a short role play showing how a ventilator-associated pneumonia develops from a simple road traffic accident. So, from crash to cough, a case of BAP. So, now let me introduce you all to my team. Dr. Lavneet as an ICU consultant, Dr. Prempal as senior resident in the Department of Anesthesia and Critical Care, Maninder as ICU nurse, Kaushal as patient, Khushbu as patient's attendant. So before starting, let me give you all a quick overview of our role play. So our role play will unfold in total 3 scenes. Scene 1, patient is brought unconscious after road traffic accident. Our anesthesia team has stabilizes him.
Doctor, this is a 32-year-old male and brought after a road traffic accident with the head injury, and he is unconscious with shallow breathing.
Okay, first evaluate the ABCD and check for the vitals, and we'll do the GCS scoring.
So GCS is basically used to assess the level of consciousness in a patient, usually after head injury. It has mainly 3 components: eye response, motor response, and verbal response.
The SpO2 is 84%. The GCS score is 8 by 15, and the pupils are equal and reactive.
What should we do next, sir?
Prepare for intubation. We'll intubate him and call Dr. Prempal. He'll be assessing us, and take the consent from the family.
Sure, sir.
So, hello, Dr. Lavneet.
Hello, Dr. Prempal.
What's update here?
So this is a patient of head trauma. His breathing is compromised, and the GCS are the vitals, and the GCS is 8 by 15, and I think we should intubate him. So you will be assisting me in intubation.
Okay, doctor, let's do the intubation first. Sister, start preparing for endotracheal intubation.
Yes, sir. I'll take the consent first.
So they are performing simulated intubation and attaching it to the ventilator. Nurse has also taken the blood samples for blood transfusion if it will be needed. So intubation has been performed and patient is on mechanical ventilation with medical and supportive management.
So sister यहाँ पे intubation हो गया. So keep him on control ventilation. Start IV lines. Initiates antibiotics and we will shift him to ICU for monitoring and care further.
So we saw that they have intubated the patient as his airway was compromised. Coming to the scene 2, ICU setting, day 5 of mechanical ventilation. Dr. Lavneet is on rounds now.
Yes, Marinder, any updates on the patient?
Yes, sir. The patient is not maintaining SpO2 as 94% despite oxygen support, and he has also developed fever, high-grade fever, 101 degree Fahrenheit
Okay.
since last night, and his ED secretions have also become thick and purulent.
Okay, he has been here for like 5 days, na? Okay, so it's going towards web, I think. So, any other findings on the chest X-ray?
Yes, sir. New patchy infiltrates on the right lower zone.
हाँ जी डॉक्टर साहब, what's happening here?
डॉक्टर साहब ये देखो, इसके राइट लोब में पैच इनफिल्ट्रेट्स प्रेजेंट है. And he's developed a fever 101 Fahrenheit overnight and is not associated with any symptom, but the secretion, the ET secretion have become purulent. So I think it's going towards VAP. We should do the CPI scoring.
Exactly, Dr. Lavneet. Let's calculate CPI score first.
Okay, so the TLC count is 14,000 and fever is 101 Fahrenheit. Patchy infiltrates are there. Purulent secretion is present and oxygenation ratio is 220. So the score is 8, sir.
So as you are saying, Dr. Lavneet, CPIS is 8, so it is highly suggestive for VAP, I think.
Yes, sir. We should send the tracheal aspirate for culture before starting the antibiotics.
So sister, send the sample for the culture and start with broad spectrum antibiotics and modify according to the culture.
Should we continue with the head elevation and suctioning also?
Yes, exactly. Reinforce the VAP bundle.
So can you please elaborate about VAP bundle?
Yes, let me explain you. Firstly, head and elevation 30 to 45 degree, then daily sedation vacation, oral care with chlorhexidine, and maintain hand hygiene before and after sectioning, and close the sectioning system.
So in the ICU setting, we all know the silence is rare. Every beep has a meaning. Our patient has been on a ventilation for 5 days, but something has changed now. He developed fever. His O2 levels are dropping even after intubation, and thick secretions are also appearing in the ET tube. So our anesthesia team has made the clinical diagnosis of VAP by using the CPIS score. So what is this CPIS score now? So CPIS defined as clinical pulmonary infection score. Basically, it has 6 components: temperature, leukocytes, tracheal secretions, oxygenation, chest radiograph, and culture sensitivity. So coming to the scene 3, day 7 of ICU.
Yes, Mahinder, what's the other report?
Sir, I have contacted the microbiologist and they have confirmed the growth of Pseudomonas sensitive to piperacillin tazobactam antibiotic.
Okay, so it's confirmed, it's VAP. So tell her the further
Yes, yes.
treatments.
Yes, Dr. Lavneet, it's WAP. So, sister, keep him on with broad spectrum antibiotics as piperacillin tazobactam and continue the WAP bundle also.
अभी भाई आपका रिकवर कर रहा है पहले से बेटर है लेकिन धीरे धीरे होगी रिकवरी नहीं लेकिन इतने ऐसे दिन हो गए आईसीयू में है मतलब क्यों इतने ऐसे दिन से रखा हुआ उसको निमोनिया हो गया तो इसीलिए उसका निमोनिया कैसे हो गया मैंने आपको बताया था ना शुरू में कि उसके जो हम सांस की नली डाल रहे हैं उसके कारण उसको कॉम्प्लिकेशन हो सकती है निमोनिया हो सकता है तो वो चीज है आपकी गलती होगी ना तो निमोनिया होगा तो ऐसे कैसे होगा आप बड़े डॉक्टर से बात कीजिए आपको बाहर मिलेगा
डॉक्टर साहब आपने क्या किया है भाई के साथ मेरे छोटा सा उसका एक्सीडेंट हुआ था और आज उसको आपने रखा हुआ आईसीयू पे
क्या हो गया बच्चे का? नाम क्या है पेशेंट का?
नाम इसका रवि है
अच्छा, हाँ उसको हेड ट्रॉमा हुआ था, लेकिन हमने उसको वेंटिलेटर पे रखा था। आपको मैंने पहले भी बताया था कि वेंटिलेटर पे अगर उनको रखेंगे तो उनको कुछ रिस्क फैक्टर्स होते हैं
लेकिन
वेंटिलेटर
उसको निमोनिया हो गया ऐसे कैसे हो गया निमोनिया
वेंटिलेटर पे ज़्यादा देर रखने की वजह से इन्फेक्शन हो जाता होता है, निमोनिया हो जाता है। हमने उनको ट्रीटमेंट स्टार्ट कर दिया है, दे आर इम्प्रूविंग। सो आप घबराने की कोई ज़रूरत नहीं है, आप थोड़ा शांत हो जाएं।
So, as we see in the critical care, preventing infections like VAP is as important as managing the initial trauma. A ventilator saves life, but careless handling can take it away. So, this case demonstrates how a road traffic accident patient on mechanical ventilation can develop ventilator associated pneumonia. But early diagnosis using CPIS, culture based antibiotic therapy, and adherence to VAP bundles are essential for good outcome.
Bundles break the barriers and prevent the patient safe.
Evidence guided the cure.
Diagnosis made the difference.
So, VAP once a threat, but now a lesson. Together, we can breathe safer, care smarter, and save lives. Thank you all.
Before the whole scenario is open for the judges, I have some comments to make. One is that you really made a scenario which was looking like realistic. Only thing is, since I have to talk about counseling, you made really excellent arrangements of showing the case. But when we were talking to the patient, attendant, at that time ऐसे कैसे हो गया वो आपको बैठ के उसके साथ we couldn't just stand and talk to her. We had to first make her sit, and it had to be at her eye to eye level, understanding the whole scenario, validate what she says, and then we say whatever we want. So our counseling, probably you did excellent as far as this is कैसे हो गया. Usually हम जब पहले use करते थे hospital acquired pneumonia. So nowadays we don't use that. It is interpreted by the patients, attendants कि ये डॉक्टरों की गलती से ही हुआ. Most patients attendants feel कि हमने तो छोटी सी करके लाए हैं, but आपने बाकी चीजें बहुत अच्छी दिखाई. Thank you, well done. Only thing is I felt bit counseling जो हो रही है ना ये थोड़ी सी जरा थोड़ा शांत हो ठीक है ना. That was required.
I would like to invite upon stage Dr. Deepika for the case discussion.
So good evening to all. So it was a typical day in ICU. So as we see, the case was really nicely portrayed with all the props and the dress code. Nicely done by the students. I would like to congratulate them. And as ma'am nicely pointed, the ethics thing, that was a bit missing in the communication part. Um, we should all follow the spikes protocol. It is a protocol when you can communicate with the patient in a really nice manner, which emphasizes, like, it is S stands for setting up the scene, P stands for perception, I stands for invitation of questions, K stands for knowledge sharing, E stands for emotion, and S stands for summarizing the things. So we can always counsel the patient by in a nice manner so that they can feel that we are really empathizing with them. That part was a bit missing in the scene, and you can really communicate well with the patient. Rest, the GCS assessment was a bit not accurate. The rest of the things were really good, and the treatment provided was very nice. So in VAP bundle, that is a infection prevention bundle, we can use 5 things to prevent VAP. Number 1 is head elevation of the bed. Second can be the chlorhexidine mouthwash, followed by the peptic ulcer prophylaxis, DVT prophylaxis. So all these things can be really followed. We can use tubes with the subglottic suctioning, that can also help in preventing VAP. So all these things should be taken care of in ICU to prevent the patients from any iatrogenic infections. Thank you.
Thank you so much, ma'am, for the insights. Now I would like to, ma'am. अच्छा ठीक है ठीक है. Now I would like to invite upon stage Dr. Bhavneet Bhati, Dr. Pooja Saxena, Dr. Ritu Gupta, and Dr. Ravneet to please felicitate Dr. Deepika. ये क्या है? किसी किसी चीजें आती रहती हैं।
Some observations regarding the role play.
Okay. Good evening, everyone. I think almost good evening. Okay. That was a fantastic role play. A huge round of applause to all the actors. So, a few observation. Maybe, something that we need to look into our practice. Who takes the consent in your hospital? Any consent. Who takes the consent? Who should be taking the consent? I need some reply. Who should be taking the consent? Who took the consent? I think it happens everywhere. Doctors just sign. There's no doctor's sign on your consent form. There are 3 people who sign on the form. One is the patient or the patient attender. Second is the doctor. Third is a witness. So your witness can be a nurse, but the one who is taking the consent has to be the doctor. And there is never a hurry to explain the complications. Had you spoken about the complication, the rapport that you create with your patient is the most important thing that would save you later, even if there is a complication. So spend that 3 minutes extra in the beginning so that you don't have to spend 30 minutes later explaining them. And in any infection prevention, the first and the most important thing is the one and only thing, hand hygiene. Hand hygiene comes first in everything. And in WAP, 2 other thing that is very important is, yes, the elevation. Third, a close suctioning, because sometimes the saliva or the oral secretions, if it is pooled here, could cause some aspiration and infection. So a subglottic suctioning. That, I think I already mentioned 3. What is the 4th most important thing in WAP prevention or a COTI prevention or a line related prevention? Not line, but okay, COTI, is to assess the removal, whether the patient requires that thing inside, the tube inside. So a sedation vacation is important to assess his general status, when I can remove. Okay, so that is why this 4th thing that is very, very important. Thank you.
Actually, we do not get, as facilitators or teachers, we do not get an opportunity to actually have these feedback. Had it not been the role play, it would have been very difficult. So it's only through role play we were able to observe the issues of intervention. Otherwise, I think everything was going fine. And we did get them to do a role play, but we did not observe. And we could see where we lack. And maybe it's only thing is it's because of the age
and the wisdom. And but I think we can explain. It looks like spikes when they will speak spikes, वो फिर monotone बोलेंगे, spikes है, ये है, वो है, वैसे करके बोलेंगे. They will not actually have that empathy, going, speaking, sitting calmly, not hurrying. So these are the skills actually we used to learn when, I can say, from PGI. Though there may not be an excellent way like NMC tells this to do, this to do, but we had excellent role models. So we learned by observing our role models. So that's how we learn, and that was there. And I think maybe their role models are doing like this. That it's a reflection for us too. It's a reflection for us too. So may I, the team, who's starting?
मेरे को खांसी आ जाएगी बीच में, पूछ के anybody has MacBook.
Excuse me, students, if anyone has a MacBook, we need for some time. Anyone? MacBook.
इसी में रख लें आगे मतलब तेरे स्पीकर ही है ना ऊपर इसके यार वो बंद हो गया खुल नहीं आता थोड़ा सा
थोड़ा आगे कर दो, वो तार खींची पड़ी है.
स्पीकर ये है एक्चुअली या तो इसको ऐसे रख दे बस 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 इधर से कह दूंगा यहाँ से आइसक्रीम बाकी दें
You must have heard that beautiful musical snippet. So that makes us move to the next and the final activity of the day, a musical one. So let's introduce it with a little poem. She stirred her pots with practiced grace, a steady hand, a smiling face. But in her gut, a secret slept, a germ that through the city crept. She felt no fever, coughed no sign, yet traced through every food and line. A silent spreader, first well known, who left disease where she had flown. They mapped her path with patient care. Each case a clue hung in the air. With cultures, charts, and sharp review, they found what Mary never knew. Now, in her name, the lesson stays that health can mask infectious ways, a paradox in human guise, the cook who taught us to be wise. Let's uncover the truth behind the woman who changed public health forever, presented by the MBBS students and our little champ, Sri Shani Vashisht, the historical landmark of life of Typhoid Mary.
सर ये कहाँ से होता है भी जैसे मतलब वो ऑडियो सोर्स कहाँ से चेंज होता है इसमें ऑडियो सोर्स
इसको तो बच्चा खोल के था अच्छा
Points of view of video. This is Charles Edwin.
इसको छेड़ना शुरू कर
The story of Mary Mellon begins from the Warrens in 1906. In the points of view of women, Mrs. Charles Eliot Warren had John Parkinson. It's such a big household. I have my husband, my 4 children, and those 5 servants. I need a good cook, and not to mention all those dinner parties and Sunday teas. Hello, this is Mrs. Chitra's service agency. How may I help you today? Hello, I am Mrs. Charles Eliot Warren, the lady of Warren household from Oyster Bay. I need a good cook for my household. You know what a respected family like ours want from a cook? Sure, Mrs. Warren. I'll send my best cook to you right away. Mary Mellon was sent to the Warrens' household to work as a cook. She was an Irish lady. She moved to US in 1883 at the age of 15, leaving behind her parents in Cookstown County, Tyrone in Ireland. She was a private person, talked little about her past life, but had sterling references for her job. She proved to be a great cook for the wealthy families of America, including the Warrens. Every day, Mary used to wake up in the shelter provided by the Warrens early and got ready for the long day. Oh God, again this freezing water and this ridiculous soap, which turns my hands raw. I wish there was a better way than this. Anyways, let me get dressed fast, otherwise I might get late to work.
Buy these peaches, the best peaches of Oyster Bay. The finest and largest peaches of the season have shown up.
Oh, are you sure of the peaches quality, mister?
Yes, of course. I've gifted these peaches to President Roosevelt, and I think you should not miss these peaches in tonight's ice cream.
The Warrens would love to have an ice cream in this scorching summer tonight. Great, let me buy these peaches and some fresh cream. Everything was going great at the Warrens when suddenly, towards the end of August, 9-year-old Margaret Warren felt too tired to play with her sister and brothers.
Oh, my sweet summer child, what curse had fallen onto you? I hope you get all right. My heart aches seeing your playful soul lie here tired.
One month had passed after the Warrens were infected. Mary had quit her job after the Warrens left the apartment. The health authorities had thoroughly conducted an investigation but were unable to reach a conclusion, so they attributed the issue to the water supply. The apartment was originally owned by the Thompsons, who had rented it to the Warrens for the summer. Worried on this revelation of typhoid erupting from their mansion, they were determined to get to the bottom of this.
Oh God, this is a nightmare. How do you rent your house next summer after this?
What has our house got to do with all this? The health authorities have ruled any possible contamination in the house. They have told us that it was the infected water which caused the worries.
Oh, George, the Warrens made it to the headlines. You know how the LA Pass is. Remember how the mansion next street had been empty since the last 5 years after Miss Starks fell? All there was a gardener infected now, but people chose not to go there.
Oh, you're right. This is indeed a grave situation. I know a cemetery agent, Dr. Soper. What a fine man he is. His word would surely get the lights back to your house.
Yes, I believe this is a good idea. I will climb right away.
Welcome, Dr. Soper. The missus must have told you about the situation. It's a great relief to see you here. Thanks, Mr. Thompson. It will be a pleasure helping you out. I'm the hard guy. You worked here before. Was there anything or anyone new here with the Warrens?
Well, there was this cook Mary who had recently joined us but left soon after the Warrens caught the illness.
Hello, this is Mrs. Stricker's service agency. How may I help you today?
Good afternoon, Mrs. Stricker. I am Dr. Soper, and I have been hired by the Thompsons to investigate about the typhoid rampage at their place. I heard you were the ones who dispatched Mary Mellon. It would be a great pleasure if you hand me over the details of the households she worked in previously, and also where is she now? Oh God! 6 of the 7 families I made contact with have been hit by typhoid. The common one? Mary Mellon. So, where do I find this Mary Mellon? If I find her, this might mean a Nobel Prize for me. This will be the first carrier of typhoid in the United States.
Sapper finally tracks Mary to house in Park Avenue belonging to the Bounds and decides to pay a visit and convince her to give a stool and urine sample.
Miss Mary Mellon, I am Dr. George Soper and I am here to help. I believe you are a carrier of the typhoid. You are unintentionally infecting people. Please help me and cooperate. So, all I need is a sample of your blood, urine, and feces, just to rule out the possibility.
You bastard! You half-wit! How dare you say such preposterous thing to me? I have never fallen ill. Leave alone typhoid? You dare to come in my kitchen and ask me such a thing?
Sapper starts following Mary every day until he found out where Mary lives. She bought food for a man named August Brehoff every day. So, Sapper befriended Brehoff and one night sat with Brehoff drinking.